All right, good morning. We're gonna get started. So welcome to part 2 of MonteHeart. We have very large shoes to fill after yesterday's session. I think we all agree those are very high level, high quality presentations. There were scripts, crisp, they were elegant, and they were educational for all of us. So I hope we can achieve the same thing that Uli and his team were able to achieve. This is, as you probably glanced at the brochure, is more of a surgical and therefore much more fun session than yesterday was. Yesterday was about diagnosis and images and what you can do with wires. This is what, we're gonna go with the fun stuff today. Before we start, I just wanna thank Uli for being our fearless leader, for putting all this together. Azim and I just sort of grabbed on his coattails, but he put all this together and managed to create this multi-campus program, which required a lot of hair pulling. So thank you, Uli, for doing this again after a 3-year hiatus. It is my job to present the chair. Someone obviously needs no introduction because he's one of our own, but Dave D'Alessandro is here. Dave is a associate professor at Harvard Medical School. Hopefully within the next year, he'll be full professor, Dave. Dave is a talented surgeon, an out-of-the-box thinker, a world expert in sarcasm, almost unrivaled by anybody, and a great friend for over 20 years. So Dave will serve as chair of this first session. Dave, thank you. Thank you for being here. It's great having you. So why don't we get started? Omar, one of our talented cardiologists, heart failure cardiologists, will give the first 2 lectures. Omar.
Thanks, Danny. It's great to present this session. This topic is near and dear to our hearts. We are seeing a lot of these patients. So I'm going to start by what defines cardiogenic shock, and this is a universally accepted criteria. So hypotension, blood pressure, systolic blood pressure of less than 90 for over 30 minutes, and especially if you need vasopressors or inotropes to maintain that, as well as hypoperfusion, shown by a low urine output of less than 30 mLs per hour, or an elevated lactic acid. These are pretty basic things, but important to pay attention to, because as we will see, recognition of cardiogenic shock early is essential. And then we move on to the other 2 things, which sometimes you need a PA catheter, but actually can be estimated non-invasively through echo and a central line. So a cardiac index less than 2, and an elevated intracardiac pressures, a wedge pressure over 15. So you have to really pay attention if these things are happening to the patient and recognize this problem early on. What is the epidemiology of this problem? This data is from the nationwide inpatient sample. This captures a lot of hospitalizations. This is data for over 1 million hospitalizations spread from 2004 to 2018. The line in the middle is the non-AMI cardiogenic shock, which sometimes doesn't get as much attention, but you can see there's a lot of those cases, and it's really about half and half. So it's not all ischemic, but you can see the prevalence of this problem and the incidence, they're all rising over time. It's not going away as the population ages. There's more of this cardiogenic shock happening. And STEMI, it's also about 10% of the patients that have STEMI are going to have cardiogenic shock. So very important to recognize that this is a rising incidence. Of course, what's essential to recognize once you understand the patient has cardiogenic shock is why is it happening. So this is data from Critical Care Cardiology Trials Network of 16 ICUs. It's a sample of about 700 patients. You can see there's a variety of etiologies that can cause cardiogenic shock. The ischemic problem is about half of it, but then there's a lot of patients with non-ischemic etiologies, and more specifically, etiologies such as valvular problems or other things like myocarditis. So those are all very important to recognize, because sometimes you kind of miss the forest for the trees. But if there's a specific etiology that's happening that's addressable quickly, it has to be fixed. Otherwise, the problem is not going to go away. I think we're good with ischemic problems, but sometimes the non-ischemic etiologies, such as valvular problems, can get missed. Moving forward, so how are these patients doing once they get admitted to the ICU with cardiogenic shock? So inpatient mortality, this is again data from this national inpatient sample, is very high still. You can see in the recent years, either if the shock is from an ischemic problem or a non-ischemic problem, the mortality is very high. So on average, around 40%. So nearly half the patients, even now, that get admitted with cardiogenic shock are not going to make it out of the hospital, which is really bad, especially if the incidence of this problem is rising. Now, of course, age is a poor prognostic marker in nearly every disease, but I was actually kind of surprised at how bad it is in cardiogenic shock. If we draw the line at 65 years old, so regardless of the ischemic presentation or a non-ischemic problem, you can see either of these graphs that if the patients are over 65 years old, they have a considerably higher mortality. So those patients really, if you have that an older patient or 65, all hands have to be on deck because their mortality is very high. There have been some studies that have shown how we can treat cardiogenic shock, especially in an ischemic situation. So this was a shock trial. This is published over 20 years ago. These were patients that were in cardiogenic shock. They met those criteria I mentioned earlier, and they were randomized to medical therapy or revascularization. And the patients that were revascularized early on did better. You can see at 30 days, more of them were alive. Then later on, there were long-term data that were published for this trial. What's remarkable to me here is that even though they did better, they made it out of the hospital. Over time, these patients still have a very poor prognosis. You can see at 5 years, regardless of what arm the patients got into, a lot of them, didn't survive. So it's one thing is to get them out of the hospital, but also even afterwards, these patients are at very high risk. They have to be in a heart failure system, because eventually their disease will further deteriorate and they may need more advanced therapies beyond the initial revascularization and medical therapy they received. Moving forward, there was another study that was done more recently. This is the culprit shock trial. This was the idea when patients are presenting in cardiogenic shock from an ischemic problem, whether randomize them to the culprit lesion only or do multivessel PCI, fix all the other lesions as well. And what was found is that it's better to just fix the culprit rather than addressing everything at that time. And so either way, the composite primary endpoint, which was a mix of things written here, or just death, both were lower in the patients that just had the culprit lesion addressed. So this is important and it's added to the knowledge of how to manage this problem. But moving forward, it's just, you can still see though, even the patients that did better with culprit PCI only, the mortality in either arm is still very high. So this is, it makes a little bit of a difference, but why is that? Why can't we just do better? So to dig into it a little bit, when the patient is in cardiogenic shock, the LV function is poor, the perfusion is very bad. What's going on, if you dig in a little bit more, is there's this spiral that happens, you can see here, because of poor perfusion, there's further vasodilation, the SVR drops, there's reduced coronary perfusion, and this just releases a cycle of inflammation and cytokines, and eventually the end organs will deteriorate. So even if those interventions are done, the process really has to start pretty early on, which of course starts with recognition of the problem in the beginning. Now, there's this concept of damage to the microcirculation. So we don't have any interventions to deal with the microcirculation, but it's an enormous vascular bed, right? It's much bigger than the acute problem. So the schematic show, so number one, the pictures that you see, is the bottom one is the patient in cardiogenic shock. This is the sublingual microvessels. And in those patients that are in cardiogenic shock, you can see there is fewer of them. They're just damaged. So the microcirculation is very sensitive to lack of perfusion. So initially, we see the patient, we recognize those criteria. There is reduced macrocirculatory perfusion. It's easier to recognize. But what's also going on, if that macro perfusion is not fixed very early, that the microcirculation will start to get damaged. Okay, but then you say, well, if we fix the macrocirculation with medical therapy or devices, maybe the microcirculation will just improve. Doesn't happen. There's this discordance. So if the timing is lost in the beginning, the microvessels may not get better. And that really is much more relevant towards preserving end organ function. So timing and treatment I think are absolutely essential early on for this problem. So now, how do we recognize this? I went over those criteria, but there's another staging system that's talked about more recently. This is a little bit more generalized system. But the idea here is not to get lost in those small details of what is the actual cardiac index, what is the actual lactic acid, but really just to look at the patient at the bedside and stratify them into these more obvious criteria and define how severe the shock is in the beginning. So this is the SKY criteria. This is A through E. They're listed here. You can see a patient who's at risk or starting to get worse, is in classical shock with clinical evidence of hypoperfusion, creatinine may be rising, or if they're deteriorating, or if they're an extremis. So this is an important and a quick tool at the bedside, and it does relate to prognosis. You can see all these different studies here. When you separate the patients into the different categories, they have worsening prognosis. A little bit of a concern, some of the categories do overlap in prognosis, which makes this not incredibly distinguishable, but it does define things in the beginning pretty quickly, so we can get moving, especially on the more sick patients. But this is the real world, right? You define the patient in the beginning for a certain SKY level and prognosis, but they fluctuate. Patients will start at one level, and then 2 hours later, they're going to be sicker, and then the next day, they're going to be much sicker. So it's more than just, the initial recognition is one thing, but this is a disease that will change. This is a longitudinal follow-up thing, and patients can go back and forth. And of course, if somebody has chronic heart failure, it's a whole different game. The acute presentation of new onset disease is different. It's a different phenotype than patients that already have heart failure and then they get worse. So those sort of patients don't fit well in this scheme. So it's good for initial recognition, but really to get a handle of things and to understand the longitudinal change, we have to use pulmonary artery catheters, and we have to understand hemodynamics as they're changing. Now, as soon as I say PAC, there's a lot of resistance because a trial that was published 2 decades ago studied if pulmonary artery catheters are of any use. So this trial was actually done in patients with decompensated heart failure, the ESCAPE trial, and it showed that if you got a PAC or you didn't get a PAC, it made no difference. So then everybody's like, well, in fact, the patients who got pulmonary artery catheters had more adverse events. So the idea was, well, this causes more harm. It doesn't make any difference in survival, so forget about it. But the issue is these are not patients in cardiogenic shock. As you can see here, they had okay blood pressures. They didn't meet criteria. So cardiogenic shock is an entire different ballgame. These sort of data are not applicable to those patients. There is a randomized controlled trial that's going on at Tufts, I believe, that will study the efficacy of pulmonary artery catheters in cardiogenic shock. But just clinically, day to day, we believe strongly that hemodynamics derived from pulmonary artery catheters in cardiogenic shock patients are essential. There's some data that show that if you have a PAC in place, it does associate with differences in prognosis. This is data from the cardiogenic shock group. That's a registry of several centers, and they took patients and separated them into 3 categories. Those who had PACs in place and had a complete assessment, that's the black category. In the middle in red is those who had an incomplete assessment of hemodynamics, and in blue are the ones who had no assessment of hemodynamics. And then in the bar graphs there, you can see how the patients did. So the ones that had a full assessment, had a lower mortality. I mean, you can argue that maybe those patients just weren't that sick. There was enough time to get hemodynamics. It is associative data, but there is at least some association that if you are able to get these numbers, they will aid in management of these patients. Now, even further though, I put these 4 situations out here where unless you have a pulmonary artery catheter in place, you can't really understand what's going on. So all these 4 scenarios have the same blood pressure, but in the one on the left there, this is a classical situation of LV failure when the wedge is high, the artery pressure is okay, and the PA pressures are elevated because of the left-sided problem. Cardiac index is low. Moving on, you see the next case where the RA pressure is actually greater than the wedge pressure. We can't know this without a PA catheter in place. If you're just looking at the blood pressure, it's the same pressure, so you can't tell. If you put a PA catheter, you realize that the second patient is an RV failure, so we're going to have a different management. Of course, there's a issue. Sometimes patients have biventricular failure. Here, the filling pressures on both sides are elevated. And then the last scenario, this is actually a very common scenario and probably not talked about as much, even though we see it all the time, is mixed shock. Many times patients will present with left-sided heart failure from an MI or a non-ischemic problem, but then they're going to vasodilate because that whole inflammatory cascade, and they're going to be on pressors, and it's going to be extremely difficult to sort this out without a pulmonary artery catheter in place. So mixed shock is a common scenario, and a PAC catheter assists in diagnosing that. Now, once we get the diagnosis and the hemodynamics, what can we do? So for me, the management of cardiogenic shock really relies on two basic principles. One is decongestion, and the other is perfusion. That's it. Those are the basic fundamentals of management here. You can decongest patients that are in shock unless the fluid is removed out of the patient, even if they're on vasopressors, even if their blood pressure is low. Unless that's just one of the few therapeutic things we can do. So decongestion is very important. If we have to use renal replacement therapy, then so be it. But the filling pressures have to be reduced, and we'll see why in a second. But to do that, diuretics are used, dialysis, but then we move forward into the perfusion zone, which of course is essential. You got to perfuse the organs to limit that microcirculatory damage. And there's a variety of tools that can be used for that. So inotropes is something that's immediately available. Those can be used. But then we move forward to this more exciting area of temporary mechanical support. Balloon pump has been around for a long time. There's ECMO, which has a rising use over the past few years. There's Impella, and a lot of that is going to be talked about to the other sessions today. There's the two different types of Impella that are more commonly used. And finally, there's a durable LVADs and heart transplantation. Those two things at the bottom are actually very difficult to do in the acute setting. And as we move forward, we're starting to understand that doing that sort of thing in very sick patients may not have the best prognosis. So it's better to stabilize the patient with temporary devices, decongest them, and then if they're having no signs of recovery, then move forward into these more durable solutions. I'm going to go a little bit into this pressure volume loop concept. Even though we don't use this in clinical day-to-day management, I think it does helpful to understand the physiology and the pathophysiology and the effect of the different interventions that are done in this disease process. So initially, this is pretty straightforward. This is a combination of the LV pressure. This is the pressure in the LV pressure, and then volume on the x-axis. So we start here as the mitral valve opens, the LV starts to fill, and then the valve closes, and then there's a period of isovolumic contraction. And then the aortic valve opens, and then there's ejection. So this whole part of the curve is really the afterload. This is where eventually there is equilibration between the LV and the aorta. And finally, the aortic valve closes. And then there's a period of isovolumic relaxation, and the loop starts over again with the next cardiac cycle. So the heart really has 4 phases, not 2, not just systole and diastole. There's these 2 things in the middle, these isovolumic periods. The loop lives between these 2 lines, the green line, which is the end systolic pressure volume relationship, and the blue line, which is this end diastolic pressure volume relationship. These are important to know about because these are the things that will change with different interventions, but they confine the pressure volume loop. Now, as we move, one thing to keep in mind is that the green line is a representative of the contractility of the heart. So unless you're doing something like giving somebody dobutamine or really affecting agonizing the beta-1 receptors, the contractility is constant. And then the afterload part of the curve I talked about when the valve is open. So I went through those things because once we understand the loop a bit, we can determine the effect of the different things we do to the patient. So the green loop is really the normal heart if you don't have heart failure and cardiogenic shock. And in the pink purple there is the heart failure cardiogenic shock loop. So number 1 is shifted to the right and it's smaller. The width of the loop is the stroke volume. And this is the reduced, right? Patients in shock, there's not much blood coming out of the heart. So the loop is small and it's shifted way to the right. The filling pressures are much higher. So we get that. So what happens when we put this sort of patient, right? So we're at the bedside, patients in cardiogenic shock, we got to support the blood pressure. Let's start them on a bunch of LVAD. Okay. So when that's done, this is what starts to happen. Is the LVAD has these properties of beta-1 agonist, but also alpha agonist. So you can see here the contractility will rise, the slope is rising, but also the loop is shifting upwards. this whole afterload zone, this part of the curve that I talked about, this thing, you can see this is rising, right, from before. This is not good. This means a lot of pressure is being put on the heart. The heart is already failing, and now with the norepinephrine, it's increasing afterload. So as a result, the stroke volume, the width of the loop is actually smaller. That's not something we want to do, right? When we want to improve things, perfusion, we want to widen the width of the loop. But this intervention with levofed, although it improves the blood pressure, it actually reduces stroke volume by raising the afterload. And you can see in the loop how that's happening. Now, what if you do dobutamine? So this has beta-1 properties and not really much of an alpha effect. So when we do dobutamine, you can see here that now what's happening is, so the beta-1 receptors are being agonized and the contractility is increasing. And that effect is much greater than any sort of afterload increasing effect. And now the loop is wider. Now more blood is coming out of the heart, right? So this explains why dobutamine is actually going to create a greater stroke volume, not levofed. And we don't have that much of a rise in afterload. The problem with these agents, though, of course, they're going to cause side effects of arrhythmias. So we can't really keep using them. We have to move forward with something else. So this is where the temporary mechanical support devices come into play. So which device is placed depends on a lot of factors, right? How much support is needed? Somebody's on multiple drips, they're hypoxic. They may need a device that provides greater cardiac output and also ability to oxygenate, such as ECMO. Vascular disease is critical. These are large bore catheters. If somebody has terrible peripheral vascular disease, you're not going to insert a large cannula in the femoral artery. Even if it is inserted, the legs will become ischemic. The patient's not going to do any better. LV thrombus is very important to recognize. This is sometimes tough, because there's an intervention going on in the lab. But it's important to know that, especially if an Impella is being considered, make sure the patient has a clot in the heart. Comorbidities are very important. Patient has end-stage dementia, end-stage cancer, that may change the equation a bit. And logistics, where the patient is going to go after, especially if they're being transferred. Can the receiving hospital handle an ECMO or even an Impella? So that's important to consider. And finally, and this is a little bit later on, what is the ultimate prognosis? Is the patient recovering, or are we going to have to use other sort of more stable platforms that give more time? But the initial decisions are a little bit complex and related to these factors. So TCS or temporary mechanically support is beginning to be more commonly utilized. The major one that's used these days is balloon pump. So in the orange is all the temporary support devices in a setting of shock. So about 20% of the patients, regardless of ischemic and non-ischemic reasons, get a temporary device. Most of it is still balloon pump. So the gray line is that. But at the bottom, you see here, there's a rising use of these other devices, such as ECMO, or in yellow is essentially the Impella device, the PVAD. So there's greater use of that. Balloon pump is our go-to still, right? There's data I'm going to talk about a little bit that it didn't help much in a ischemic situation, but yet a lot of it is still being used. And so this is a device that relatively is simple to put compared to the other ones. It has two phases. In diastole, it inflates, and in systole, it squeezes. That second thing, when it deflates in systole, is actually the part where because of that deflation effect, there's like a vacuum effect, and then it creates a lower afterload. You can see here in the loop here, when the balloon is deflated, that's where this afterload is reduced. The loop shifts downward, and that actually will increase the width of that loop a little bit, causing an increase in stroke volume. It's not much though, right? There's not much of a difference. So that's why balloon pump, you can't get a lot of output out of it. There was the SHOCK 2 trial, IABP SHOCK 2 trial that was done to see if in a ischemic cardiogenic shock situation, is balloon pump helpful? The patients were randomized to balloon pump or control, and it made no difference. At 30 days, there was no difference in outcome. One thing to note is there was also not any major side effects. So these two red boxes show that regardless of balloon pump or control, the stroke incidence is very low. So, although it didn't have a lot of efficacy in this trial, we didn't cause harm either. And bleeding also is this is going to become a little bit more relevant when we start talking about the other devices. But at least a balloon pump, it's not going to cause a greater side effect. Now, so then why isn't it just abandoned, right? Why not just forget about it? Well, because there happens to be a group of patients that are responders to balloon pump. This is data from the initial shock trial. Remember that the shock trial that revascularized patients. What they did was they looked at a subgroup of their patients that were responders who got the balloon pump and then their hemodynamics improved. So there are some patients that respond to balloon pumps. And if that happens, then they do fine. They do much better. I mean, this was a post hoc analysis. We don't know in a randomized setting. You could envision doing a trial of just enrolling those potential responders to balloon pump, no balloon pump. But clinically, we see this, right? Some patients just respond. And Dr. Castana is one of our fellows. You know, he put together a registry here. We looked at over nearly 500 patients. What he did was, you know, they had swans in place so we can measure serial cardiac indices and determine what are the predictors. What can be determined immediately in the cath lab before the balloon is put in? What factors will lead to more response? And these are such as things like BSA, so bigger patients, they may not respond as well. If the initial cardiac index is very low, that's not so good. But if the patient's RV function is preserved, they may respond to balloon pump because the problem is really in the left side. So there's also other retrospective studies that show, you know, several other factors that predict better response. So there's a subgroup out there. And this is a randomized control trial that's actually being done in Italy, I believe, that's looking at balloon pump in decompensated heart failure without an ischemic problem. So we'll see if in the non-ischemics, whether balloon pump has any efficacy during cardiogenic shock. Moving forward to Impella, right? So this is a device is used, beginning to be used more and more commonly to support the patient. It is able to produce a greater output through the device, of course. This is different from the balloon pump, which uses the native heart. This device can just remove the blood out of the left ventricle and put it in the aorta. So the Impella can be put in femorally, and Dr. Ford is going to talk also about Impella 5.5, and Dr. Goldstein will go through the new trial that's being done, which the Impella 5.5 provides much greater output. So these devices are coming around. One thing to notice is what happens to this pressure volume loop during Impella. So you can see, you know, number one is shifted downward a little bit. So it's a lower afterload, but also the loop starts to change, right? It's triangular. It's different than the usual loop. This is happening because the Impella is distorting the cardiac cycle. There's continuous unloading. Same thing happens with the left ventricular assist device, a durable device. But either way, if there's continuous unloading, the regular phases of the cardiac cycle are distorted. So it's a triangular loop. And on the A line, of course, is more flattened, right? There's reduced pulsatility, and the pulse pressure is reduced in the flatter A line. Moving forward, so what is the data for Impella use in cardiogenic shock? So there was a hemodynamic study done, this ISAR shock study, which looked at cardiac power, which is a determinant of how much blood is coming out of the heart, with balloon pump versus Impella. And you can see the numbers are more favorable. The cardiac power is higher with the Impella in place. And at the bottom, there is a lactic acid, and that's quickly reduced with Impella compared to balloon pump. This data doesn't capture clinical outcomes, it's just the numbers there. On the right there was an attempt at a study, a randomized controlled trial to compare balloon pump versus Impella during cardiogenic shock, and you can see the curves are overlapped. The problem here, of course, is the sample size, right? We can't study these things in 50 patients. The authors, this is a statistic concept, so if you think that the effect size of your intervention is going to be very big, if somehow the Impella is going to reduce the mortality in this difficult problem by 35%, okay, and then you think the mortality is 95%, maybe then it makes sense to enroll 50 patients. But that's not the case, right? We know the mortality is around 40%, and we know there's not going to be any single intervention that's going to reduce the effect by like 30, 40, 50%. That's not, best case is going to be like a 10% improvement. I'm just going through this because when these trials are designed, we really have to understand what is the problem and what is the effect of the intervention. There is another initiative that's ongoing. This is a National Cardiogenic Shock Initiative. This is a single arm study where the patients are selected and they go through this streamlined pathway to get early intervention through an Impella, and the authors have reported the results. One thing you can see here is that this is pretty selective, right? A lot of the patients are excluded. So when they hone down on this subset of patients that presented with shock and they get an Impella, the results are impressive. So 72%, much higher than the 40% are discharged. But the issue here is a single arm. We don't know the effect of a different intervention, and they're selective. So What about just randomized control trials with Impella? So these have been attempted, but one thing that sticks out here is how many of them were discontinued early. This is not an easy thing to do. Patients are very sick. It's hard to consent them. And sometimes a patient may get sicker, so they may cross over to a different device. So there is a study all the way at the bottom that's, I think, being planned called the RECOVER study by Abumed. And we can look out for that. And there is planning to study the effect of Impella during cardiogenic shock through this trial. There's one that's ongoing in Europe called the Danger Shock study, which is second from the bottom. And that's enrolled, I think they expect to enroll about 360 patients. It seems like they're about 2/3 of the way there. So we'll look out for those findings. Okay, so what happens when the patient gets an Impella in place? This is something we see in the CCU, right? There's a lot of side effects. So this is a registry data from the CAT PCI and chest pain registries comparing balloon pump versus Impella. So the mortality is higher. That you can argue maybe the patients that got an Impella were just sicker, right? So they matched them, but you can't really match for everything. So, okay, fine. But what about the bleeding? The bleeding is a little bit more specific because it's a larger catheter, but how much of it, the magnitude. So here we can see here the patients that got the intravascular microaxial device had a 31% of them had major bleeding versus 16% in balloon pump. So that's something to keep in mind. A lot of times we just have to remove this device because of this problem. All right, I'm going to move forward a bit to discuss ECMO. There's a lot of talk about this, how ECMO can help us in cardiogenic shock. It's not just talk, because if you look at this graph, this is taken from the ELSA registry, there is an exponential rise in the use of ECMO in general. This is data from over 500 centers. At the bottom, you can, and about half, these are all ECMO, so VV and VA. And at the bottom, it's split up, but you can see about half of them are VA ECMO. So this registry has over 20,000 cases, and then all the way to the right there is the survival. So about half of the patients that get cardiac or VA ECMO survive to discharge. If you happen to get this during CPR, obviously the survival is lower. Now this is, there's no randomized control studies, but even registry data, otherwise you would expect these patients to have a terrible prognosis, right? If you end up on ECMO, then if you didn't, then probably wouldn't survive at all. So it does have applicability. And this data, again, taken from ELSO, shows how often per center is ECMO used in the different regions. You can see in North America, a given center has about 25 cases on at a median of. Our center here actually uses ECMO a lot. We're in the upper quartile here at Montefiore. So what's going on when ECMO is used for cardiogenic shock? So just briefly, there's a catheter that's placed in the femoral vein, which drains the blood out into the pump, which is moved forward, oxygenated, and then the blood is then taken back through a catheter into the femoral artery. So this is bypassing the heart. The pump plays the role of the heart, and also the lungs. The membrane can oxygenate the blood and then remove carbon dioxide. So in effect, we're bypassing the heart and lungs. Can be deployed at the bedside, which is a huge advantage. Of course, the catheters are very big, so that may lead to side effects. But I want to just talk about this loop for a second on ECMO. So this is the effect on this is in the LV loop. What happens when we just rev the ECMO circuit up, right? Flow it faster and faster. So as we're doing that, 1 liter, 2 liters, 3, 4, and 5, the loop is getting very small. That's kind of intuitive because a lot of the blood is being drained from the ECMO circuit. What is a little bit less intuitive is this whole shift in afterload. Remember this part of the curve I talked about? This is the afterload. This is rising. So the heart is already bad, right? The LV is dysfunctional, and we're using ECMO to support the patient. But at the same time, a lot of afterload is being presented in front of the left ventricle, which can lead to some side effects. So digging a little bit more mechanistically on why that's happening. So this is a schematic of a patient on ECMO. So we turn up the pump, turn up the ECMO flow. This will reduce the preload because it's being drained through the pump. But ultimately, the blood is going to come back into the aorta in front of the left ventricle. And that's why that whole loop is shifting upward and the afterload is rising. this retrograde flow back to inflame the aorta creates a high afterload, which in effect will then lead to aortic valve closure. There's just too much pressure in front of the aortic valve. Once that kind of thing starts to happen, there's no outlet. I mean, there's still some blood going through the native circulation into the LV, but once you close the outlet, then the problems can start, like pulmonary edema, there's back pressure into the lungs, could be pulmonary hemorrhage, and stasis in the ventricle causing LV clot. So these complications in ECMO are important to think about, because although you may be able to support the patient, we don't want to lose a battle here if the patient has a severe side effect, like a stroke or pulmonary hemorrhage. So because of this issue with high afterload, there's a concept of LV venting, where we can put a vent in the ventricle through different methods, ultimately to reduce the pressure there and to prevent those sort of side effects. And this is fairly commonly done. And a common way to do it is to use a percutaneous ventricular assist device. So this was a paper that was published in JACC to see what happens when you use a vent during ECMO and the outcomes of that. So number one, you can see the vent use overall. Overall, the ECMO cases are rising, which are the bars, but also the uses of vent, especially the PVAD use, which is the red line, is rising. So what happens to the outcomes of these patients? These are associative findings. So one thing that's, you look at it, you're like, whoa, the mortality is lower with vent use, with mechanical unloading, so it must be useful. The problem is, again, this is an association. We don't really know that's the effect of the vent. It may be the patient that received the vent were just less sick, right? There's a difference in somebody who just crashes and ends up on ECMO and didn't survive versus somebody who is sequentially getting sicker. They get the Impella first and then they're upgraded. That's a different patient. So I don't know if the mortality data is hard to tease it out, but one thing we also see though is the side effects. So there's more bleeding, there's more hemolysis when the vents are used. So because of these issues with the adverse events, we've developed this algorithm to really avoid indiscriminate use of the vent and really use it in a more personalized, individualized fashion. So our patient will get on ECMO, and then we would observe them unless, of course, they have overt pulmonary edema. The swan we put in, echoes will be done. We can get different parameters, like how often the aortic valve is opening, what the pulse pressure is, and the wedge pressure. If those are elevated, meet two criteria, then inotropes can be used to open the valve and reassessments. And if the criteria are still there, then a vent can be considered. The importance of side effects. So this is another registry study that was published using the ELSO registry. So on ECMO, there's a lot of side effects that happen, right? Bleeding and thrombosis are the two categories. And what the issue though is that these sort of side effects actually lead to are associated with a worse prognosis. And the major issue is really stroke and bleeding. So there has to be, although ECMO can provide support, unless we find ways to mitigate these sort of side effects, the ultimate prognosis may not improve. One thing we looked at here with our own patients retrospectively is if we looked at the plasma-free hemoglobin, which is a measure of hemolysis, if it's elevated, those patients have an association with higher stroke. So this clinically has led to closer monitoring of these markers. And if we see them rising, we want to consider removing ECMO or moving to a different device. But what about the efficacy of ECMO? Even though it's rising, does it actually do anything? So there was actually a randomized controlled trial that was published. This was done in Prague. This was published last year. So these investigators, what they did was patients with either ischemic or non-ischemic cardiogenic shock, if they met certain criteria, then they were randomized to early ECMO, so at the initial assessment, or just the conservative management. And you can see here the patients were pretty sick. I'm not going to go through all the numbers, but they're on drips. Most of them are on vasopressors. About 75% of them, I think, are intubated. So very sick patients. And the primary endpoint was all-cause death or resuscitated cardiac arrest, another device. The curves were not separate. Ultimately, there was no statistical difference. But again, this issue of power, the authors or the investigators assumed that there would be a 50% reduction with ECMO use. And that led them to an analysis where they would only have 120 patients. So, it's a little bit generous to assume that ECMO is going to lead to a 50% reduction in this outcome. So perhaps a larger study would have showed things differently. There are a couple of studies going on in Europe of ECMO and cardiogenic shock. So one is a Euroshock study, and the other is ECLS shock. These studies are planned to be completed this year or early next year. So we'll look out for those results. One concept that's risen, and I think this is at full display at our own center, is this concept of a cardiogenic shock team. This is data from Utah. The idea is that, once a patient is recognized to be in shock, the heart failure cardiologist, the cardiac surgeons, interventional cardiologists, the critical care attendings, they all get together and decision is made on which way to go, especially if there's a, so first decision point is whether there's a STEMI or not. And if so, the patient is revascularized. And even if there's no STEMI, they get a right heart cath. And then depending on the hemodynamics, temporary devices are considered and a left heart if also needed. So through that approach, these investigators showed in their center, there was a reduction in mortality. So the patients after the shock team implementation had better survival. Here at Montefiore, we have a little bit of a different model. So here the CCU is staffed by a heart failure attending. So when a patient presents in shock, that's usually where they're going to end up. So the first call is, to the heart failure team or the cardiac surgery team. So, there's a very close-knit sort of communication, that same concept. But here, because we're staffing the unit with the heart failure team, it's not just the initial contact, it's also what happens then afterwards. As I mentioned earlier, these patients are going to change. The disease is not like a one-shot fix. So we've implemented this process where we can have longitudinal shock team, basically, not just at first exposure. So this is data from our own center as before and after this model in the unit, and you can see the cardiogenic mortality is lower from 28% to 23%. Again, this is associative data. Maybe the patient characteristics play a role, but at least there was observational improvement. So, just kind of closing up here, this is a proposed pathway of cardiogenic shock. I think a lot of this will center on early recognition and consideration of transfer to a center such as our center, a tertiary care center, which can provide all the different phases of care. But early recognition is key. Knowing the etiology is key, and that's going to happen through echo, left heart cath, and a PA catheter. And we have to restore perfusion, decongest the patient, and reassessment is very important. Sometimes those things only work for a little bit of time, and then the patient gets worse. I think it's critical to avoid adverse events. The patients are already on the cusp. If they get a setback, they may not do well. And then ultimately, we'll have to see if either the patient is recovering or they need another sort of destination therapy. I think this is sums it up. There's a rising burden. The mortality remains high, as I noted. Care pathways are going to play a critical role in this disease, as the flow graph on the prior slide. And there's a rising role of usage of these temporary devices, especially if we can lower their adverse events. And we'll see what the randomized controlled trials show that are ongoing. Thank you.
Let's do the changeover. I think Omar, I think this was the best electron shock. Actually, I'm not making it up, as you know, that I've ever heard. Really amazing with all the concepts as we understand them at this moment in time. We can change over the slides. Any questions from the audience? Or Dave, you can take over.
Can we get the other panelists to come join me at the Last Supper table? I think we've got Dr. Goldstein, Dr. Lateeb, Dr. Bliagos. You want to come up and join us?
Last Supper table. Be careful with those bed sheets. They are expensive.
That was absolutely an outstanding review on a lot of data. Omar, you talked a little bit about the SCAI classification of shock. I think that's been a real step forward in the field that gives us some real granular data on how these patients are doing. And I think that's going to give us a better idea going forward of how our interventions affect how outcomes. We at our center, I don't think are using it very well in a prospective fashion. Are you using SCAI classification? Are you using it as an algorithm when to institute inotropic therapy or mechanical circulatory support? And if so, how do you do it?
We are using it. We're so used to using. We are using it, but I will say we're so used to using the hemodynamic details that I think the SCAI sort of precedes that. But once you start talking in the hemodynamic language, then that's the numbers sort of guide what therapy is going to be used. So I think it has a role initially, especially where there's no PA catheter in place. And so we start to use it, but we move forward to using the numbers.
When we look retrospectively, I think a lot of that is reimbursement data. And as we get more aggressive in identifying shock so that we can bill more I'm not sure how useful those are in retrospectively looking back at outcomes. So I think for this to be as powerful as it could be, we have to very clearly document where patients are and when they're escalating or when they're de-escalating in the shock criteria.
Yeah.
I think we need to do a better job collectively.
Omar, I was actually going to say.
I was actually going to say the same thing that Uli said, which was best shock talk I've ever heard. But I had a question. You know, and I always ask this, is that we have a lot of devices that restore circulation acutely, and none of them seem to have moved the needle. And I have to say that the trial from Europe that looked at early ECMO use, which was the thing that we were always talking about, was the one thing that we could fix. The fact that that was a negative trial was a little bit disappointing. Should we be looking at other pharmacological agents or other stuff to improve on shock?
Yeah, thanks, Neil. Based on two things, I think the jury is still out on the effectiveness and the efficacy of this. I think an appropriately designed trial has to be done. There are limitations to those studies, such as greater sample size and really defining the specific subset of patients to enroll. Not every cardiogenic shock patient, as we tried to show, is the same. But your second point, I really do think there's a role still of pharmacologic therapies, new therapies. So inotropes have been used for a long time. They have a lot of side effects. That's not what I'm talking about. But other stuff, we know that there's inflammation that plays a key role in this process. COVID taught us, right, new therapies to reduce inflammation. So I think as time goes on, there's going to be room to investigate therapies that can reduce that during cardiogenic shock and whether that has any benefit. I think no matter what you do, though, pharmacologically or mechanically, it's got to be done early.
Just a few comments. Terrific. I think this slides that should be handed out as people walk out the door. So the problems with shock, number one, most of the literature, 95% of the literature is MI shock. We know very little about non-acute MI shock. And in fact, the incidence and prevalence of non-acute MI shock is higher than acute MI shock. So that's one problem with literature. Number two, as you have pointed out clearly, there's no good randomized trials in this field. Almost all are underpowered. So I have a question for my two cognitive colleagues next to me. This whole concept of unloading before opening a vessel, right? And Naveen Kapoor and others have spouted. Where do we stand on that? You think there's a validity to it? And what are we doing at Montefiore?
Who's going to ask the easy questions, don't you? So I think when you look at the preclinical data that Naveen and his team have accumulated, So there's this whole new concept that, when patients come in with a occluded coronary artery, our approach has always been time is muscle. Open up the artery as quickly as possible, restore flow, and you will save more myocardium that way. Now, there's a challenge to this concept, and the challenge is that many times when we open the artery, even though we're restoring flow, we're causing macrovascular reperfusion. So the angiogram looks good, but if you look at the microvasculature that we don't see, and that makes up more than 80% of the blood vessels of the heart, that's not being reperfused. So the ST segments don't come down as quickly, and that there's this continuous damage to the heart, which there's a term for it, we call it is microvascular occlusion. So how do we improve that? I mean, probably in as many of 50% of patients where we do a successful primary PSAN open the artery, they have microvascular occlusion, which is why sometimes we see young people get an infarct, we open their artery, and then 2 years later, they're in horrible heart failure and they've been worked up for transplant. There's a lot of different techniques to try and how do we improve microvascular reperfusion. And one of those concepts is, can we do unloading? So the idea would be patient comes in with an occluded artery. We put in a Impella device into their left ventricle. This unloads the ventricle, decreases the wall stress, and then 20 minutes later only we open the artery. Now, that's a really challenging concept for many of us who our entire field has been about open the artery as quick as possible. So for us, it's been challenging thinking about, do we introduce a study like that into our practice, which goes so much against what we've done in the past, but also too, it has an impact on us as an institution, because in the United States, maybe it's different to Spain, there's a lot of public reporting, and all our door-to-balloon times are publicly reported. Suddenly, we would become an outlier in New York State by having the longest door-to-balloon time. So that's kind of the challenge with it. So right now, we've not been doing, but it's an interesting concept.
So the concept here is door to unload as opposed to door to balloon, right?
Uli, final question for you. We just saw all the data for cardiogenic shock, and when you look at it as Omar did and just reviewed with us, it's really humbling that we think we know what we do works. We know inotropes work. We know balloon pumps work. We know PA catheters are helpful. We know Impellas and ECMO work. But when you look at the data, there's no randomized evidence that PA catheters work, that balloon pumps work, that inotropes work. None of it works when you subject it to randomized clinical trials. Could it be that we're just wrong?
Here we go. You might well be wrong. We know that. So quickly we have to move on, but balloon pumps don't work is not true. Balloon pumps don't work in patients with cardiogenic shock from a STEMI. We know that. That's shock too. But the 50% of the population that it works in, we need a randomized trial in that population. And the grant I spoke about yesterday on balloon pumps we're doing here will contribute to that. Right-heart cath, there's reasonably good literature that in shock, if managed in a cardiac unit, they actually improve mortality. It's just that one heart failure trial, where ESCAPE trial, which is very much a faulty trial because people came in and the physician thought they do not need an inotrope. They're not in shock. And then they put the catheter or not. So it's just the wrong population. We need to do these trials. The right trials have not been done.
All right, so we'll move along, hopefully with less data-heavy slides. The next speaker is Dr. Forrest, a well-known surgeon here, needs no introduction. He's going to speak to us on Impella use for ECMO-supported patients.
Thanks, Dave. Really great talk by Omar. I'm happy I talked to him before we made our slides because I had to get rid of all my pressure volume loops as well. So it's good to know what he's thinking at bedside when he's telling me to change the pump or to put in a vent. And so really excellent. So we start with a case presentation that a lot of us were involved with, including Omar, who we were actually seeing this morning at bedside. But this is a 56-year-old woman who's small, 5 foot tall, 132 pounds, who presented with 1 day of sore throat, cough, had a panic attack the night before. And she called EMS, family called EMS. She was at a graduation over the weekend, otherwise healthy. That when the EMS team arrived, she had a mean arterial pressure of 40. She was tachycardic, arrived in our emergency department within our, not here at Moses, but within our system. Again, hypotensive febrile, and she was intubated. Blood work revealed that she had a leukocytosis of 31, acute kidney injury, transaminitis, and a troponins of 30. And a bedside echocardiogram is performed. And this is in the emergency room within several hours of presentation. She had rapid escalation of pressors. You can see her echocardiogram here with severe biventricular dysfunction. Again, a 46-year-old woman, previously healthy. So what do we do at this point, and what happens within our hospital system? So we get a consult for ECMO. So as Omar was saying, what is ECMO in this case? What is veno-arterial? ECMO comes in two flavors, veno-venous and veno-arterial. For the sake of this conference, we're talking about veno-arterial ECMO. It's complete cardiopulmonary support, and how we do that. Drainage from a venous system, and we reintroduce it after passing through an oxygenator into an arterial system. I'll show you a little bit of different options that we have from that. It bypasses the pulmonary circulation, well, most of it, as Omar showed with the pressure volume loops. We can drain most of the right heart, but at the end of the day, you're still going to have some blood going through the pulmonary circulation into the LV. And the difference between cardiopulmonary bypass and ECMO is that we don't have a reservoir and we don't have drainage that we have in the operating room to give us a completely drained heart. And so while we capture most of the blood, we can't always completely decompress the heart. Again, a venous arterial cannulation strategy. I'll show in the next couple slides the different options we have. And what do we use ECMO for? We have it as a bridge to recovery. We can use it as a bridge to decision. We have a new patient. We don't know exactly what's going on. We have to figure out, is it RV failure? Is it LV failure? Is it related to the lungs, et cetera? We can use it as a tool to transplant and select patients who we know who are in our system, who are part of our heart failure team, and we can use in rare occasions to transplant the patient and use this device as a bridge to that. More importantly, we use it as a bridge to other temporary mechanical circulatory support devices. And I'll go through a lot of those later in this slide. Again, that's depending on the etiology of the failure. And so we have two options. We have peripheral cannulation strategies, as shown here. Probably our most common strategy. We insert the venous cannula into the femoral vein, arterial cannula into the femoral artery. This can be performed at bedside. And we have also central cannulation, which will be relevant later in this discussion. This requires a sternotomy approach, or at least a thoracotomy approach, where you're cannulating the right atrium directly or the aorta directly. For cannulation technique, this is what we use either in the chest or in the groin. It's a 16 or 18 French arterial cannula. The larger the cannula, the less afterload you have in the system, and the higher you can flow. Our venous cannula is the range of 23 to 25 French, and this is a longer cannula. It has to be placed ideally into the right atrium. You can see that we have several drainage holes here that can be passed into the right atrium. There's another variety of this cannula that can be placed in the SVC or the IVC to drain the blood. And again, this is just based on the patient size and what we think we need to have appropriate drainage for the ECMO circuit to flow. Our technique for doing this, again, we mentioned at bedside, using a ultrasound to access the femoral vessels and Seldinger technique. If we're lucky, if the patient is usually in the emergency room, in ICU, whatever it may be, if we're lucky, we can use ultrasound and get a subxiphoid view, where we can view confluence of the right atrium and IVC to see a wire pass up and allow our venous cannula to get into the right atrium appropriately. This is not always accessible, as the patient may be getting compressions, too sick, or a habitus that is prohibitive of obtaining appropriate views. You can see here the middle hepatic vein, always a feared complication. If you have resistance inserting cannula, you do have to be careful of placing that. If we're lucky enough to be in the cath lab, we have fluoroscopy, or in the operating room, we have TEE that can be used to help confirm our wire placement and cannula placement. As I said, a majority of our patients who are having ECMO, including this case, is going to be someone who's going to be at the bedside, as they're too unstable to transfer and require immediate insertion. So this young woman underwent a cannulation, transferred up to the CCU and underwent cannulation at bedside. You can see here, this is an X-ray, abdominal and of the chest, showing post-cannulation. You see the tip of the cannula. We have a little bit of room to move up, but you have drainage ports running all through here into the right atrium, and you can see how it traverses up to the IVC across above the diaphragm. And similarly, you see in this area right here, you have the arterial cannula in the femoral artery. And so, as Omar had alluded to in a few of his slides, what are the complications of ECMO? So the patient is going to be systemically heparinized for insertion of the cannula, and we try to maintain systemic anticoagulation while on support. Though this is clinically, this may vary based on the patient's clinical situation. So bleeding is the most common complication. You have indwelling cannulas, and so infection must be considered. Limb ischemia is carefully monitored with serial exams of the limb, including Doppler evaluation of the leg, and also with our vascular colleagues, we have immediate consultation to evaluate the limb perfusion with arterial duplex as well. Acute kidney injury is as expected in someone who's in shock and stroke when on device support. How do we deal with the complication of limb ischemia or prevent the complications of limb ischemia? We see here a venous arterial cannula in the groin, and if you look off the side of the arterial cannula, we have what's called a distal perfusion catheter. This could be inserted into the superficial femoral artery. In this case, you see it sort of traversing out of the screen, going down into the foot, into the I forget, the dorsalis pedis, and they can have a retrograde flow up the leg to preserve the leg. I show this slide because it's not uncommon once the patient is cannulated, and this is actually the case. Once the patient is on ECMO support, you will have a heart with a lot of afterload that is not ejecting, and so you get this flat line on the arterial line. PA wasn't attached here. This would indicate a well-drained heart, but this is not uncommon. So when you start seeing this, we start thinking, what do we need to do to have this patient ejector to vent the left ventricle? Here we see, this is again, after the patient was cannulated, we have a echocardiogram here. We have a flat A-line tracing. You see that the aortic valve is not opening. Maybe you may have a little component of some root stasis and smoke and in the ventricle when you're evaluating these patients. And so when we're bedside with the multidisciplinary team, we're now saying, what do we need to do to make sure that the heart's ejecting? We don't want the LV to develop thrombus and have the concern of stroke. So this is from one of Dr. Saeed and Dr. Yordi's papers looking at our different options to unload the left ventricle. We first evaluate our non-invasive approaches. If the patient is not on an inotrope, they usually are by this point. We initiate an inotrope to allow for the heart to eject. This works on occasion, but then we have to start thinking of mechanical ways to vent the left heart. And we try to do this in a stepwise fashion, going from least invasive to more invasive. We'll start with a balloon pump as a first measure to allow for some afterload reduction and just try to get a little bit of ejection. It's interesting. Try to get a little bit of ejection from the heart and allow the aortic valve to open. If the patient was already in the cath lab, it is not uncommon that they already have an Impella CPN, and so we'll have that device in place that's already venting the left ventricle. Other techniques we have that are seen in the middle row include an atrial septostomy, which is going to allow blood from the left atrium to go into the right atrium, which is going to be vented via the venous cannula. And similarly, we have other techniques to vent, other surgical techniques, including a surgical Impella, which is the Impella 5.5, or a surgical vent, which is the catheter directly inserted into the LV via a thoracotomy or sternotomy approach. So the patient was placed on ECMO. Again, this is all within the first 6 to 12 hours of the patient presenting into our emergency room. Patient underwent a left heart cath revealing normal coronary anatomy, and an endomyocardial biopsy was performed, and a right heart cath revealed these numbers. And so the decision was made that without the aortic valve opening, then intra-aortic balloon pump would be inserted. As you can see here, she was on really massive doses of pressor support. A mixed vasodilatory cardiogenic shock picture. She was flowing an ECMO of 5.1 liters. BSA was notably 1.8. And so we obtained an arterial duplex. We identified that there was in fact flow all the way down the legs. And so despite having palpable warm legs, and excellent flow on arterial duplex hours later, it was noted that the patient was having increased CK. She developed cool to touch below her ankles, and a compartment pressure was performed of the lower extremities. So the decision was made to take the patient promptly to the operating room for bilateral fasciotomy. So the patient went to the operating room. She had the fasciotomy. She was transferred back to the ICU where she was resuscitated. The conversation is happening at that point. What do we need to do? The patient is suffering from limb ischemia. She has a distal perfusion catheter in. She has a balloon pump in the left groin. She has ECMO in the right groin. And so the patient has bilateral lower extremity ischemia, and we had to make the decision. We need to convert from peripheral ECMO to what at this point? We need to preserve our lower extremities. The kidneys are being insulted from the rhabdomyolysis. And so we made a decision to go to the operating room to repair the femoral vessels and change our strategy for perfusion. Patients taken to the operating room. This is the echocardiogram that we have. So there's mild improvement at best of the right ventricle, and left ventricle still pretty horrific. And so we still had the picture of mixed cardiogenic vasodilatory shock. The pressure requirement was decreasing. The patient was still in shock liver, acute renal failure transaminases in the 8,000s, and severely coagulopathic. So you have to make the decision in our algorithm. And I thought, Omar had a really great slide I'm going to ask him for after this. What's going on? We know from our right heart cath that we have a picture of both LV and RV dysfunction. The lungs on X-ray surprisingly look okay. And so the question is, do we need an oxygenator or not? Maybe not at this time, but with the systemic response to everything going on, she may go down the pathway of ART. And so this decision here is going to be biventricular support with or without an oxygenator. And more importantly, in a small patient who is 5 feet, we have to see what options we have from the surgeon's perspective. Where can we insert devices? How can we insert devices? Can we move the access up into the axillary system? And that's going to be an ECMO approach. That may be an Impella approach. And or do we have to access everything centrally? And so the other consideration we have when we talk about inserting devices into the heart is also the size of the heart. This is a lady who's 46, previously healthy, who has a small normal ventricle. And also we need to consider how much flow are we going to need for both sides. And so this is a patient who I think we're going to need complete support for both the RV and the LV. Central strategies. So this is via sternotomy. We have an option for biventricular support. We really haven't used this in the recent past, and this is where we are doing surgical biventricular device support, where you have drainage from the right atrium and return via the pulmonary artery for right ventricular support, and drainage from the left ventricle into the aorta via a second pump. In this schematic, we have central ECMO, which is a right atrial drainage and return via the aorta with a surgical LV vent where you insert a drain through the apex connecting to the venous system. And so you're draining from that and allowing the LV to remain decompressed. Other options we have is a percutaneous approach with a right ventricular support. This is a cannula called the proprietary cannula called the Protect Duo cannula. It's a dual lumen cannula inserted through the right internal jugular vein, pass into the pulmonary artery under fluoroscopic guidance. It's a 29 to 31 French cannula. You can see here that you have one port aspirating from the right atrium and re-injecting via the pulmonary artery, plus minus with or without an oxygenator. If you need to insert this device, this can be performed under fluoroscopy and TE guidance. And other, not completely percutaneous, but with an axillary cut down in sternotomy, you can insert a pump through the axillary artery, the Impella 5.5, which is a 19 French, which has a 19 French pump motor. And this blood inlet area is going to be inserted in the left ventricle and the outlet area just above the aortic valve. And so those are the options that we're thinking while we're taking the patient to the operating room and what's going to be our best strategy. And so this is a 5'1" woman. Her right axillary artery is 3 millimeters that wouldn't be able to accommodate an Impella device. She needs biventricular support. And so we elected to proceed with doing central ECMO. And you see here, this is a post-procedure chest x-ray with the right atrial cannula.
Steve,
Yeah.
sorry. I just want to get the pulse of the audience and the panel for a second here.
Yeah, of course.
Because I've been listening very intently, and I see a woman who is as close to death as you can be. She's on massive doses of inotropes, massive doses of epinephrine, dobutamine, norepinephrine, completely vasodilated, possibly infected. She has been instrumented with ECMO, large cannulas in the groin, and now, if I understand that correctly, you propose to take her to the operating room, open her chest, and put in something else. Maybe you showed a couple of equipment pieces at $30,000 a piece. Is that something I would like to hear from Dave? And I would like to hear also from Joe from Barcelona. Just not the long, but just a brief impression. Is this?
Yeah, 10 years ago, that patient would have gone to the OR and gotten Centromag, biventricular pumps. We don't use those much anymore in our practice. I don't think you do anymore here. Just the surgical associated bleeding is high. I was going to ask Steve, it seems to me like maybe her lower extremity malperfusion was not necessarily your cannulae, but just globe malperfusion. And once you reperfused her, that's the repercussions of that. If that were the case, you'd expect that her end organ dysfunction really profound, which appears like it is. I would have been tempted to, if the distal perfuser was working and if it looked like she was getting perfusion after the fasciotomy, I'd be tempted to just leave her on peripheral support and try to take care of her other organ problems. But I think what it looks like you've done here is probably a reasonable alternative that maybe is better. I don't know.
Yeah, no, that's a great point. I think you're 100% right that the lower extremity malperfusion, I think, was from the pressors in the vasodilatory state. We had to vent the left ventricle. The balloon pump was in. Impella, we investigated before the balloon, putting in a Impella CP through the groin, but her vasculature was very small. And I think if I was going for a thoracotomy to place an LV vent, why not just go full out and go through the chest, eliminate everything for the groin, and let the legs recover the best we can.
I missed the balloon. Did that go in before ECMO?
No, the balloon went in immediately after ECMO.
So
when they did the left.
You're a believer that a balloon unloads the ventricle on ECMO.
In rare cases, it does. Yeah. I actually have a great. I didn't include it in here because it's not a very good picture, but I have a great tracing from the bedside. It appears that the aortic valve is opening.
Yeah.
Based on the balloon, but we confirmed on echocardiogram it is not. But
yeah, I agree. LV decompression is very important to prevent lung congestion and to help recover the ventricle. But first, you have to systemically rescue them. So that wouldn't push me to do something different necessarily, unless I saw lots of MR and flooding of the lungs or that sort of a thing. But it looked like you probably had enough function. You might be able to get away with that for a little while.
Yeah.
Yeah, just briefly. We're still implanting biventricular Centromag. So this patient, we would implant biventricular Centromag. The X-ray, the lungs seem pretty okay. So they're not congested and they don't have respiratory insufficiency. I don't know about that, but at least from the X-ray, it doesn't look like it. So we would implant biventricular Centromag, and then hopefully the legs would recover. Which part of it, I agree, is probably not only due to the mechanical obstruction, but also the very high doses of norepinephrine and the vasoplegic patient.
I was going to ask Danny what he would do, but I know exactly what he would do. Call Steve.
Yeah.
Call May.
Okay.
Yeah. No, I mean, those are great points. And I considered the BIVAD approach. I think it's just from our institutional experience. We haven't used it in a while, and the bleeding complications, particularly in someone who's severely coagulopathic. And so if I could spare one less cannula. And the other point that you made about the lungs also, I think it's good that we maintained, that we made a move before the lungs. You started seeing edema. The wedge was going up without the LV vent. So the wedge was in the early 20s, the low 20s. And so I think it was inevitable if we didn't act. And so I think the limb ischemia sort of pushed to move a little bit on her. So here we see, so the purple's the left ventricular vent. Again, that's going to be returning to the venous system to drain the heart. So what were we, to get back to this, so what are we using, why are we using ECMO for in this case? In her, we wanted to stabilize the clinical scenario. We wanted to preserve all the end organs that we could. We wanted to maintain perfusion of her brain. We wanted to give us some time for recovery of the liver and recover the limbs. The kidneys always take a long time to come back, and so we perfuse those as well as we can. But that's going to be something that we're going to be worried about, in the period of weeks to months. We wanted to get her off pressors. We wanted to overcome that vasodilatory state, overflow the system, and I think that the percutaneous options are great in the right patient. I think in someone like this who needs an index of 3.5, ECMO is a better option where we can be flowing 6-7 liters if we need to. And so we wanted to have this patient recover from her vasodilatory state before he made any decisions about transitioning from ECMO to a different temporary device. And so this is after about 6 days. The patient returns to the OR still on central ECMO, and we bring her to the operating room. She undergoes echo. We see some recovery of the right ventricle, and we have some PA pulsatility noted on the swan, and the left ventricle has some evidence of recovery. So the patient goes to the operating room. We perform an ECMO turn down, meaning we go to the operating room, we take her off ECMO support, we clamp the LV vent, we let her have her normal physiologic state to see if she is ready to be weaned off of ECMO. When we do this, our strategy is in the operating room to have the patient off of support for 30 to 45 minutes. We have continuous TE monitoring and hemodynamics. We repeat arterial and venous blood gases to monitor the patient's cardiac index. And most importantly, we don't want rapid escalations of inotrope suppressors. So the patient did not tolerate the ECMO wean. She had adequate RV function. The LV had a persistent dysfunction. The cardiac index dropped, required increasing inopressors in the operating room. And decisions made to remove her off of ECMO and to support the LV. In this case, we used an Impella 5.5, which Omar had alluded to. We have the two options again: the axillary approach, which is not feasible in her. The chest is already opened as well. She had a small axillary artery, and so we decided to proceed with a central cannulation strategy. It's performed by a 10-millimeter graft on the aorta. You insert it under either direct visualization with an open aorta under TE guidance, where you pass the device across the aortic valve into the left ventricle. When we enter the operating room, the patient's centrally cannulated, where you see here this black dot, which is sort of in the real estate where I need to place the device. Again, a 10-millimeter graft is sewn onto the aorta. However, that needs to be 7 centimeters from the aortic valve to allow the device to insert. In her case, she had a short aorta. A side biting clamp was placed across the base of the innominate and proximal aortic arch. I had to move the ECMO cannula into the proximal aortic arch so I could insert the device. Here we see an echocardiogram in the operating room where you have the Impella device, which is extremely challenging in someone with a small ventricle. As you see that you need about 4.5 centimeters of the device in the heart, and you don't want it hitting the wall so as not to cause an arrhythmia. This is the echocardiogram. Again, the lungs look relatively well. The patient is currently, she has limb recovery. She's moving all extremities. Her livers are covered. Her brain has survived all of this. She's following commands. I made this a few days ago. She was transiently extubated 2 days ago. I was hoping to have a little bit better of an update, but she was reintubated, but she's off, she is off her inotrope. She's on partial Impella support. I'm hoping maybe this weekend we can get the device out of her with basically only her kidneys left to recover. Thank you.
Steve, that was outstanding presentation, and that is as complicated as cardiogenic shock gets. So congratulations on keeping her alive and well supported. We certainly hope she does well. We're a little bit behind, so we're going to move on to our next presentation, which I think we're going to try to make a little bit more interactive. So Dr. Vukelik is going to show us a case of Impella-supported high-risk surgery versus PCI.
Yeah. While the slides are loading, I just want to say that we now have 110 people on Zoom and untold number on YouTube. So Uli, we beat you. And there's at least 50, 60 people here. So really, really very exciting to see this sort of response to the sessions.
Steve, since we have a minute of downtime, when do you decide to put a vent through the apex versus through the pulmonary vein? Quick answer.
We've had experience with clotting through the pulmonary vein, and I think a direct LV vent is better. And also, you're not, it just get better drainage, I think, into the ECMO circuit.
Great. Rapid response case. 10 minutes.
Okay, so we, instead of doing boring cases in Impella 5.5 and cabbage, which Steve and I did on one of our patients with amazing success, we wanted to do better example of how the shock team in our context with the system works. And this is the case which involved White Plains, where Dr. Bliagos is, Montefiore is CT, ICU, CCU, heart failure, cardiothoracic and critical care team and integration, which is very important. So we wanted to have recent case which really shows integration, how important it is. So this is 38-year-old Chinese American, not significant history except rotator cuff, hyperlipidemia, which is very kind of mild, say, and no family history of cardiac history and no personal history of cardiac history. The gentleman was playing soccer or football, how we call it normally, and then developed a chest pain suddenly. Went home, started vomiting. They took him to the White Plains Hospital ED, and you can see in ED, chest pain, heart rate 77, blood pressure normal, setting normally. However, high sensitivity troponin is already elevated. Creatinine was abnormal, and he got this EKG, and you can see infralateral ST elevations. I don't want you to leave discussing by yourself. We don't have a lot of time. So what happens? He immediately goes in ED to ventricular fibrillation. Dreaded situation, ACLS was started, and that what is very interesting, we immediately in White Plains deployed the Lucas machine, which really helped a lot in this case because he was really resuscitated for an hour in attempt to get him to the cath lab. And he was defibrillated 12 times. If you did not have adequate chest compression, there would be significant chance of end organ damage anyway, which Lucas in this situation, which is again mechanical support, just outside, not inside, helped a lot anyway. So, and he's intubated to ED. And you can see our amazing team, what did in White Plains. I'm not sure that a lot of you can appreciate, but you can see there is some vessels and there is LED missing on the left side. And there is a wire. This managed to put down that and open the vessel despite the Lucas going on at the same time. So this tells you how Dr. Greenberg and the team in amazing cath lab and White Plains really managed to do that while still supporting this patient because he was constantly fibrillating and with no perfusion. He was, balloon pump was put, vessel was just ballooned, opened. Of course, there was no attempted stent with Lucas going on, and patient intubated, taken to the critical, to ICU really, and White Plains, and he was put on epi. And listen, this is a situation, I specifically put all these numbers in this like overwhelming situation because it's not easy when this patient 1 hour after arrest comes to CCU to assess, is he doing good or do you need to do anything else? There's a lot of numbers there. So, and you can see the chest x-ray is very congested. You can see really if you are trained and you look very closely, you can see there is significant problem with his ABG. So pH is 713, lactate is 12.6, and there is already shock liver developing, kidneys are not working, he's unresponsive, dilated pupils, but responding to life. and legs are cold and mottled, and you can see chest X-ray really congested, which tells us that he has elevated LVADP and then probably current support, which is at that moment balloon pump, and epi is not enough. And critical care attending recognized it, and he escalated to our team. And Mayuko, one of our CT surgeons, show up immediately and put him and starts there. You can see appreciation for Mayuko, unsung hero of our shock team anyway, and we really need to emphasize. So what should we do? Like I am kind of a little bit, because I was wanting to talk about Mayuko, I will run a little bit too often, but this is the question. And this is what critical care team recognized and our team recognized. What you do next? You can put the butamine, you can do chemical stimulation, you can activate cath lab and go to the dreaded device called Impella CP with so much problems, or you can go straight to VA ECMO. Anybody, what you will do? VA ECMO. All right, so we decided to do to VA ECMO. And you can see how the things went on the side. So now the patient is transferred to escalate the care to CT ICU at Montefiore Hospital. Again, you come in the morning, the patient is just transferred overnight, and then you look at the chest X-ray. You can see there is like a cannula there. There's a severe congestion. Of course, in all the drama, SWAN is not placed, so we don't have hemodynamic numbers. But this is the situation. And you look at those numbers and what do you say? What's going on now? Is this good enough or is it not good enough? Or do we need to escalate the care, de-escalate the care? What will be the next step? Continue current management, activate cath lab with Impella CP for mechanical unloading of the left ventricle because we see the chest X-ray is very congested. Activate OR and placed early Impella 5.5 because it has less complications for ECMO, or just start the butamine. Anybody?
I defer to the literature from Montefiore and would start the butamine.
So that will be the correct answer. So this is really an answer to Grandin paper, which showed that mechanical unloading of the ventricle is very important. Because VA ECMO, as you saw for the amazing loops from Dr. Saeed, increases left ventricular afterload, which is provoking left ventricular distension and impairing recovery, which is very important for this guy. And non-adequate LV unloading additionally can lead to, of course, if the valve is completely closed, LV thrombus formation, pulmonary edema, and hemorrhage, which can have catastrophic events. And there are a couple of options. There is chemical with the butamine, and there is intra-aortic balloon pump, which was shown in multiple trials. Some panelists don't believe it, but the question is it true or not, that intra-aortic balloon pump is helping unloading with less complication, or you need to go straight to the percutaneous ventricular assist device, which will be Impella CP, which was shown to benefit in Grandin paper, but however, at the consequence of bleeding and significant complications, which you can see it here. Our proposed pathway is that after evaluation, we go to the butamine if there is absent aortic valve opening, if the pulse pressure is less than 50 millimeters of mercury, or if the wedge pressure is 30 millimeters of mercury. If we are not able to achieve that, the next step, we are escalating to the mechanical support, trying to minimize the complications, because not all the patients are made same in this situation. I think it's very important. That's a problem with trials, because trials do not appreciate a variability of this patient group, from ischemic to non-ischemic, for chronic to early acute and things like that. And we did an echo, and you can see the heart is barely moving. But after the butamine started, aortic valve is opening, not amazingly. However, the pulse pressure was still low, and we decided to take patient to the cath lab to see is their perfusion still persisting, because we didn't put the stent. And you can see the vessel was still open, not the greatest flow. It's good flow, but not the greatest flow, as Dr. Azim emphasized, the microcirculation problem. And we can also see that when we put SWAN, the wedge pressure is low. So we are good. So we decided just to put the balloon pump as we do traditionally for STEMI, not really for unloading from the for the VA ECMO per se. And you can see the next day, there is significant improvement in vascular congestion of the lungs. The ventricle is looking fine, and you can see there is constant improvement in lactic acid is all the way down to 1.5. He's making great urine. CK is trending down. AST/ALT is trending down. Shock liver, and he was fully awake and following commands. And we, in that moment, were happy about the situation. Next day, so this is really fast how we escalate the situation. We are doing the ECMO turndown. We're trying to avoid the complications which are significant. So we turn down to 1.5 liters, still on dobutamine. At the same time, it's very important, we are following the hemodynamic situation. We want to see not just it looks better on echo, but we want to see that there is no problem with the blood pressure. The wedge pressure is tolerating this ECMO turndown, which tell us that we are able maybe to do something. So what would you do in next step? Dr. Yordi? Any of panelists?
Take it out. Call the surgeon.
I would have already put the Impella 5.5 in, and so I would have then just converted to an Impella 5.5, but you don't have one in, and now the LV looks pretty good. So you're going to be tempted to just come off ECMO, and you'll probably come off okay. The question is, are you better off supporting that ventricle for longer? And I don't know the answer to that.
That's very interesting. It's really, that's in context of unloading the concept of the ventricle. So one of the reasons we put it, the balloon pump, that we thought if the ventricle recovers fast enough that we can take VAF, that we can continue what we think is some kind of a loading or better perfusion of the coronaries with the balloon pump. So we decannulated ECMO instead of putting Impella 5.5. And this is the first further hospital closed. Day 3, decannulation. Day 5, we removed Impella intra-aortic balloon pump, and we performed PCI to put drug-eluting stent in that rupture plaque. Weaning of the butamine, transfer to telemetry for initiation of GDMT. This is discharge. This is his first follow-up, and you can see the mark here of the successful Lucas treatment anyway, so he still has that. But he's awake, he's alive, and his 2 children, 7 and 9 years old, they're extremely appreciative. Thank you.
Sasha, that was terrific. We can change over the slides. Dave, I do want to challenge your point about the Impella. So we have a patient who is on peripheral ECMO. He's doing well, endurance are good. Swan Ganz in place, the wedge is 6, and he is regularly opening the aortic valve. So what's the rationale to instrument him more? I know you said you don't know the answer, but I thought we debated that. I just want to elaborate a little bit. The downside of placing an Impella, maybe perceived by you as relatively small, but it is a very big piece of equipment that goes into the heart. Do you really need it when somebody has a wedge of 6 is contracting?
Yeah, I think in that case, you don't. Most patients, as you know, after PCI like that, under those circumstances, their LVs do not bounce back that quickly. They struggle for days and weeks. And so if your practice, so I think wait and see is good. I think starting inotropic therapy in that initial period to get the ventricle or the aortic valve to open, I think is right. I think in most patients, they benefit from early, mechanical unloading, and then it gives you an ability to get them off ECMO quickly, less than 5 days. I think, and older patients, when you leave them in bed on ECMO for that period of time, they get debilitated, as you know, pretty quickly. So I think there's a lot of advantages early on and then longer term with unloading. But I agree, and that patient did not need it, but they're just, I think, hard to predict. We're a little bit behind. I know Danny's going to run over, so we're going to go quickly through this case, and maybe we'll make it sort of interactive. But I think this is the kind of patient that we commonly see nowadays. We have technology that can help us do high-risk surgery, and when we should apply that, I think can be difficult to figure out. And these decisions are often best made in a multidisciplinary fashion, as mentioned. So this is a 66-year-old guy that I saw in the clinic with a history as shown there. He had been admitted to a hospital up north with congestive heart failure, was noted to have a dilated cardiomyopathy with an EF of 15, diabetes, former smoker. He was started on GDMT, had a pretty good workup, had a 40-pound weight loss over several months that was unexplained. He had a little bit of a cachectic look, but not terrible. His main complaint was shortness of breath, no chest pain, and no chest pressure, occasional lightheadedness. On exam, he was pretty normal volemic looking, no edema, no JVD. Here's his medical regimen, which was pretty reasonable, I thought. This is the EF on his TTE that he had presented with 3 months earlier. You can see some degree of MR, not horrific, but certainly a lot of LV dysfunction. The RV was relatively spared. Here's the left heart catheterization. Are these movies? Yes, they are. You can see he's got targets. I don't think he's a good PCI candidate. You can see multifocal disease throughout the LAD, throughout his circ, throughout his right coronary system. But he does have things to SOTU. You can see that the LAD fills from right to left collaterals. So he also had an MRI that was done 1 month earlier, which shows, again, reduced EF of 17. He's got normal biatrial sizes. He does have late gadolinium enhancement of the LV, which, I think was right around 50%. It was not an equivocal read. The left circumflex and RCA territories were thought to be viable. The LAD territory was mainly not viable, no intracardiac thrombus. So, Dr. Goldstein, what do you do with this patient if he shows up in your clinic? He's got class 2 symptoms.
Well, to engage the heart team, obviously, we have this every Thursday afternoon. We present challenging cases and attended by heart failure cardiologists, interventional cardiologists, and surgeons. We come together with a plan, what we would do with this patient. And my sense is, correct me if I'm wrong, Dimitri, you would not be too enthusiastic about taking this on.
Yeah, this is certainly a high-risk patient with severe multivessel coronary disease. We have seen patients like this week in and week out, and if they had been turned down for surgery, we've done high-risk PCI in these patients. Just looking at this angiogram, I would focus on the LAD, right coronary, probably with Impella support if this was a patient referred for high-risk PCI. There are percutaneous options for this patient. Depends on the team that they're evaluating.
What kind of Impella support would you use? And how long would you leave it in for?
That would depend on the hemodynamics pre and post procedure.
Probably the advantage is with stages, we wouldn't try and do everything in one go, right? So we'd probably, especially with those right heart cath numbers, we put in a CP, probably do his left main LAD system, stop somewhere around the second septal, so not filling his artery full of stents, and then bring him back for that right coronary artery, and knowing also that some of the collateral flow to the right will have improved by then, so we'll have multiple options on the right. So, if the cases that if surgery is not an option, we've had good outcomes when done by a complex PCI team.
Omar, have you seen patients like this with low EFs improve their EFs with multivessel PCI with coronaries that look like that? Have you seen that?
I've seen it, but it's not common. I think the revasc has to be complete. Yeah, look, I have seen it happen. It's not common. I think the revasc has to be complete. Local stenting probably wouldn't do it. An entire LAD has to be revascularized.
I agree. I think it's uncommon, and I think you might get a good visual result. But
Sorry, I stepped out, but did he have an MRI or was there opportunity?
There's the MRI there. He's got LADs. Yeah, infarcted. He's got viability in the other two territories. So treatment options, GDMT alone. Anyone vote for just GDMT? He's doing pretty well. Class 2 symptoms. Okay, revascularization. Who raise your hand for PCI? Raise your hand for cabbage. Cabbage, anyone? Cabbage. Cabbage it is. Durable LVAD. Is that a reasonable option for this patient? EF of 15.
No, he's walking around with class 2 symptoms now.
Correct. Do you think he would live longer with an LVAD or not? I do. But we don't have an ability to give an LVAD to somebody with class 2 symptoms. But with that ventricle, I think he's going to live longer. I think that's the intervention that would have the biggest impact on survival, but we can't do that.
I think the good RV, he's diabetic, and you have an Impella 5.5. I don't know I would take this case on if I didn't have an Impella 5.5.
Yeah. So that's what we did. We did an Impella supported cabbage. We did an axillary approach. This is the ventricle at the time of surgery, still terrible. Not much MR, so we did not intervene on the mitral valve. We did a 5-vessel bypass with graphs shown there. I don't typically use a lot of arterial conduits in these patients because they're going to be on pressors and inotropes. I get concerned about vasospasm. Plus, the length of the grafts tend to need to be a little longer. They're a little bit more challenging to size. I think veins are easier. We came off with the Impella. That's the view you want. You showed me a nice view of yours, Steve. You want that mid-esophageal long axis view with the genu with a pump just at or below the valve. Despite that, he did well early on, was extubated, weaned his inotropes within the early postoperative period. We had a lot of trouble with VT, and that was difficult to understand where that was coming from. It was thought to be ischemic. I knew it wasn't. But in the end, I think it was just tickling the septum causing that problem and ultimately taking the pump out, fixed him of that. So here's his echo on post-op day 17. Not much different. Post-op day 20, as I said, the Impella came out. He did get a defibrillator device and EF 3 months later, still 20%. So I think the message here is I think it's really hard to predict whose LV is going to get better and who's not. I think a patient like this, you're really intervening just so that they don't get worse. They have multivessel disease and they're ischemic. So hopefully now they're less ischemic. They'll be more tolerant of GDMT. And the Impella gives us the ability to get them through that operation, which would be really challenging without mechanical circulatory support.
Great. Quick question, Dave. We can switch to presentations. The VT, VF very early on, and then with, I guess, continuous flow mostly from the Impella 5.5. Were you concerned about closure of a graft that would cause that?
Yeah, his flows were good. It never had an issue with flow. He was getting runs of VT that, our EP colleagues weren't able to tell us where that was coming from. I've certainly seen that before with Impellas. And then people will say it's suctioning because you get all these weird signals on the Impella. I don't think it's suctioning. I think that sometimes it's just hitting a papillary muscle or commonly the septum, and it can cause that. And lowering the pump speed definitely reduces the incidence of it. So typically you just come down a little bit on the pump speed and that fixes that problem. But obviously, if you're getting it from a graphs down and you're getting arrhythmias for that reason, that's a different story. But that just never made sense to me why he wouldn't have had arrhythmias beforehand if that was his issue. Steve, did you have a question?
Yeah, great case. What's your use of the right heart cath in the index greater than 2 in a patient like this? If it's 1.6, do you approach it differently versus some of the index of 2.5?
You mean preoperatively or with?
Yeah, preoperatively. Would you take the same patient with an index of 1.5?
Yes, I would. I think So I think that when you're doing Impella-supported surgery, I think it's really important that you make that decision ahead of time and not base it on how they look coming off the heart-lung machine, because the index that you get coming off bypass is often elevated, and it's because you're on lots of inotropic support. But predicting who's going to sag at 2 a.m, I find impossible. So I think making that decision ahead of time is the right way to do it. Sorry.
Sorry, one more question. You see the heart strength follow, even though the EF went down, even though the EF was normal, still reduced. Sorry, was the LV dimension any different? Do you remember in this case?
I don't remember. I'll have to look. I don't remember
because what we're seeing in some of our Protect 4 patients, Protect 4 trial. For those of you who don't know, it's a revasc trial for ischemic cardiomyopathy comparing Impella CP to balloon pump support. And what we're seeing in some of these patients in follow-up 6 months later is that even though their ejection fractions appear to be not much different, their LV dimension is smaller, and they feel a lot better. So there may be something there, and maybe be interesting to see in that case.
So I'm up. What Dave just described was using Impella 555 in high-risk surgery. That device is not approved for that. Impella 555 is only approved for cardiogenic shock. So there's going to be a prospective trial coming up called the IMPACT trial. It's going to look at prospectively 100 patients, high-risk surgery, and the use of this preemptively to reduce the chance of post-cardiotomy shock. And I'm happy to say we have national leadership in that trial as well. So as it's been tradition over the last 5 MonteHearts, my job is to sort of give you an update on durable left ventricular assist device, current status and where we're going. And I'll do that again. We haven't met in 3 years, so things have happened. And towards the end of the talk, I'm gonna sort of add a provocative statement here, a couple of provocative slides directed to my cardiology colleagues. And Snehal and I have been having this discussion for a while regarding the conversation we have with patients about LVADs versus transplants. So my disclosures are here. I will talk about unapproved devices, but only what's available on Google, not beyond that. And I will shamelessly promote all the contributions of our team is generate knowledge in this field, particularly Dr. Jordy and myself as we move forward. The other disclosure I have to make is the success of our transplant and LVAD program is not one person. I'm the talking head, but there's 5 other people I need to thank publicly. Steve, who you just heard speak. Jamil, you here? Jamil is there, thank you. Bill Jacoblev, he's probably remotely in White Plains. Mayuko, our ECMO queen, thank you, Mayuko. And Tara Sugura as well, who Mayuko and Tara are the members of our Harvest team. So thank you again. As back 17 years ago, we had a honeymoon period in MCS. We transitioned from a pulsatile technology. This is a HeartMate XV device, big device. Half of this audience will not fit this device. To continuous flow technology, smaller, more reliable, not noisy, improved reliability. And there was a dramatic improvement in survival and quality of life. So if the story ended there, it would be a very happy ending. Unfortunately, we found out that continuous flow technology has problems. The first one is aortic insufficiency. And what happens when you put in a continuous flow device is you're pumping blood into a valve, the aortic valve is not opening. So you have pressure going back against the closed valve. And what happens is the valve doesn't open, the commissures fuse, as you see, where those little arrows are, and the valve retracts. So you get a leak in the middle. You get aortic insufficiency, which is typically central. And honestly, this is more of academic interest than it is in clinical practice. We don't see a lot of aortic insufficiency to the point that patients require surgery or require heavy manipulation of speeds. More importantly, however, has been development of mucosal bleeding, and that manifests clinically as AVMs in the small bowel and epistaxis. And there's a development of the acquired von Willebrand syndrome. And that basically is the loss of high weight molecular parts of the von Willebrand protein, which are the most important in terms of platelet adhesion. It's the same thing you see in Hyde syndrome. And why does that happen? Because of the shear stress created by these continuous flow devices, particularly the HeartMate 2 and the HVAD device, which I brought here, right? So you see the difference between this technology and what I just showed you. Quite different, HeartMate 2, HVAD. The third and perhaps more dreaded complication was development of pump thrombosis, particularly with the HeartMate 2. And that was a complication that was mortal in many cases and certainly associated with high morbidity. It almost always required exchange of the pump. With the HVAD, sometimes we can give thrombolytics and get away with it. So clearly there were problems with continuous flow technology. God did not make us continuous. He made us pulsatile, or she made us pulsatile. So clearly there was an issue with continuous flow technology. And it was obvious that no matter what we did as clinicians, we had to address these problems. The concept of hemocompatibility related adverse events, HREs, deals with that. And that's a concept that emanated out of the Momentum 3 trial, which we're going to spend some time on. And it's the sort of the yin and yang of bleeding and thrombosis. These are complications that you can get once you put someone on an LVAD, on a continuous flow LVAD. You can get bleeding, adverse events as described there, and you get thrombotic or clotting events. And it's clearly that we needed an engineering cure because there's only so much we could do as clinicians with manipulation of the pump and medications. And this is the genesis of the HeartMate 3 device. It was specifically engineered to reduce hemocompatibility events. And so how does that pump engineer to do that? Well, there's three aspects to it. Number one, wide gaps. What does that mean? The passageways through which the blood flows are much wider than they were in these two devices I just showed you, the HeartMate 2 and the HVAD. And in fact, to visualize that, if you take a cross section of the LVADs, if you take the hardware device and you slice it, and you measure how big the wide flow, the gaps are, you can stack 8 RBCs on top of each other. If you take the HeartMate 3 device, you can stack 167. So that gives you a pretty powerful visualization how different those two pumps are in terms of the passageways of blood. Number two was the absence of friction. How do you get rid of friction? You levitate the pump on magnets. There's no bearings. There's no heat. There's no friction. And that was probably the most important of these elements in terms of reducing these serious events. The third was the introduction of an artificial pulse. Now, the artificial pulse, you might think, that's going to open the aortic valve. We're not going to get AI. We're going to get a pulse. We're going to look more human than machine. No, the artificial pulse was a slowing and speeding of the pump, which you see those little white arrows. It happens every 2 seconds. The pump slows down 2,000 RPMs, speeds up 4,000 RPMs, and goes back to the set speed. And what that does is does this. It washes the pump inside. So if there's any areas of stasis, they get washed out. So these three things came together to create, hopefully, a more hemocompatible pump. The Momentum 3 trial was a test of this technology. And it was a 1-to-1 randomization of HeartMate 3, right, against the best pump we had at the time, which most people thought was a HeartMate 2, right? Same company made the devices. Now, the trial was not designed as non-inferiority, which is what commonly happens. It was decided as a superiority trial. We wanted to prove that this was better than what we had. And in order to do it with power calculation analysis, we needed to have 1,028 patients. That'll be by far the biggest LVAD trial that ever happened and will ever happen. So we spoke to the FDA, and the FDA allowed us to do this trial that was unique in a couple of ways. Number one, it allowed for interim analyses. So we can look at the data after 6 months. Does it look good? Do we need to add more patients? Yes, no. And then it allowed us to include everybody who needs an LVAD, as opposed to a bridge to transplant trial, a destination trial, which had happened in all the earlier technologies. So it's what we call an all-comers trial with interim analyses. And there was a short-term cohort, which is the equivalent of bridge to transplant, where we randomized 294 patients, 6-month follow-up. There was a long-term cohort, which we added another 72 patients, so we had a total of 366. And those are followed for 2 years, which is the equivalent of any destination therapy trial we did. And then we added another 662 patients to reach that 1,028 full cohort, followed for 2 years. Great. So we obviously benefit from this technology, presumably, but you also remember we had a fair amount of information about how to deal with continuous flow from having the HeartMate 2 and the HVAD device for a while. And these three cohorts, short-term, long-term, and full cohort, resulted in 3 major publications in the New England Journal. So let's go through each one of them. The short-term cohort, as I said, was a 6-month look at 294 patients. Now, before that, you need to understand what the primary endpoint, because this is going to be a recurrent theme. The primary endpoint of the trial was not survival. It was survival free of disabling stroke. So you have a GCS less than 3, and or need to reoperate to remove or replace the pump, which deals with the whole concept of pump thrombosis. So it's what we call a composite endpoint. And what were the results here? So there's 6-month follow-up. You see in the x-axis, the blue is the HeartMate 3, the yellow is the HeartMate 2 axial flow pump. But there's a marked difference in the primary endpoint, which started actually pretty early. Within the first week, you see separation of those curves. And this was obviously a great thing, and it led to approval of the device as a short-term support. Next came the long-term cohort. Again, same patients were followed on, and we tacked on another 72. Same primary endpoint, but now we're following up for 2 years. And here's the curve. There's an even greater separation. As you see, we reach the 24 months with almost a 21% absolute difference in the primary endpoint. Huge thing. What I'm not showing you here is the overall survival. If you just look at survival, there was no difference in survival. We were perplexed. Why is that? If they're doing so much better in the primary endpoint, why not overall survival? We'll get back to that later. And then the full cohort, remember we added another 662 patients to reach the 1,028 to have power to show superiority. And these are the curves. 2 years, Less of a separation, but still quite significant with a hazard ratio of 0.6. So this is a huge home run. Established superiority of HeartMate 3 device over the HeartMate 2 device. And the HeartMate 2 device essentially was retired, except for a few cases of patients who had a HeartMate 2 device in the past, and they thrombose their pump. And it's much easier to do a subcostal incision and put a new HeartMate 2 than go in through the middle, take the HeartMate 2, put a HeartMate 3, which some of us did, but it's a brutal operation. You do any of those, Steve, Dave? Not a fun operation. So by and large, the HeartMate 2 got retired. So now we have two pumps on the field. The HVAD, the smallest pump we had, and which continued to have popularity because surgeons liked it. It was the smallest pump we had. It can be done minimally invasive. And just it was driven by surgeon interest in the pump. So this and the HeartMate 3. This is now 2018. What are other important findings that came out that emanated out of the HeartMate 3 trial? You know, we talk about stroke. Stroke, we all hate stroke. It's sometimes worse than death. And it's always been a concern with the durable devices. So in this trial from, this study from Paolo at Columbia, we showed a couple of things. Number one, that HeartMate 3 protected you from non-disabling strokes. Almost very few patients had non-disabling strokes. You see a freedom at 2 years of 96%, as opposed to HeartMate 2. So there's a big win here. Was the second finding was quite perplexing was this. If you take all the patients who had strokes, you divide them, green line, you did not have a stroke, regardless of which device you had. Blue line, you had a serious stroke. And red line, a disabling stroke, and a red line is a non-disabling stroke. Look at the 2-year survival. That's uncomfortable. Why? If you had a disabling stroke or a non-disabling stroke, you had the same survival. And it's something we still have not been able to explain fully. Other information we got, and this is something near Columbia led, and this is going back to the engineering of the pump. Remember what I told you, it was engineered to reduce HRAEs. And in fact, what do we define as HRAE? Because I not defined it for you fully. It was non-surgical bleeding after 30 days of surgery. Why after 30 days? Why non-surgical? Because that refers to bleeding related to the pump. You don't want to include reoperable bleeding because you got a sternal bleed or something like that. So we excluded all those, any stroke or neuro event, and any suspected or confirmed pump thrombosis or arterial thromboembolism. And here are the curves at 6 months. Drastic improvement with the HeartMate 3 compared to HeartMate 2. So we've proven that this device does exactly what the engineers wanted to do. It's gentler on the blood and on the blood elements. Like any good trial of this magnitude, we included an economic analysis, and that's what I'm going to show you here. And basically, we show blue's HeartMate 3, red's HeartMate 2. That's always the same color scheme. That there was a reduction in rehospitalization, hospital days, and a savings, marked savings with a HeartMate 3 compared to HeartMate 2. It was independent of whether you're a bishop transplant, DT, whether you're Medicaid, Medicare, public-private insurance. So it was also something that most of us don't really care about, but the administrators in the hospital who write your paychecks do. Other important findings of the trial, and this is in JAMA Cardiology, when we looked at the primary endpoint outcomes for BTT versus DT, remember those are the labels that were imposed on us by CMS. You have to tell me, before you do the surgery, is it a BTT patient or is it a DT patient? We found out that the hazard ratio, the benefit of HeartMate 3 over HeartMate 2 was exactly the same. The hazard ratio, now you can read it there, was 0.62 and 0.61. So the same impact HeartMate 3 had whether you're a BTT or DT patient. Very important. And the adverse event profile was exactly the same. So that led to abandoning these labels. We didn't have to write down anymore. And it makes sense. These labels are arbitrary, they're dynamic, and they're unpredictable, right? You have a 42-year-old patient, you're gonna put this, it looks like a bishop transplant patient, you put an LVAD, they have a stroke, they're hemiplegic now, and guess what? Now they're a DT patient. Or you have a 60-year-old DT patient because he's smoking, doing marijuana, or has a high PVR. And then he stops smoking marijuana, his PVR gets better, now he's a BTT patient. So the labels were always artificial. The other thing we showed, again, going back to the beautiful engineering of the pump, is that this acquired von Willebrand syndrome was less severe on these patients. You see in the blue HeartMate 3, red HeartMate 2, the baseline is those big squares in the top. And you see there's less loss with the blue than with the red of high molecular weight von Willebrand factor. It is also might be related to the fact that we're seeing much less GI bleeding. So if you take a step back, MCS for the last 30 years and look at only survival, this was the optimal medical management, the rematch trial, which was the first DT trial in the history of MCS, which basically launched destination therapy. 8%, so 92% of people died within 2 years. The people who got the HeartMate 1, right, the big crab, titanium crab, this guy, so there's a 24% survival, so 3 times the survival. That's pretty good. The first HeartMate 2 trial, there's a 58% survival, drastic improvement, over doubling. HVAD, similar, 60%. HeartMate 2 LVAD, another trial. This is the BTT trial, 68%. A later trial, HeartMate 2, 76%. So what's very interesting to me, if you look at just those numbers, the same pump, we didn't change anything. We got better at managing the pump. So we went from a 58% survival to 76% survival without changing the pump whatsoever. And I think that has implications to what might see with HeartMate 3 as well. So let's look at HeartMate 3, 83% survival with 2 years. What is the transplant 2-year survival? 82%. So the technology's gotten good enough that we can have equivalent survival with transplantation or MCS, the current MCS. So this is really, really impactful. So perhaps the most important publication to come out of Momentum is this one, and it was in JAMA, and was the 5-year outcomes on LVAD. We've never had follow-up of 5 years. It was clear that 2 years is not enough. We call that long-term. That's not long-term. Long-term is 5 years. When we think about cancer, you talk about 5-year cure, right? If you're disease-free for 5 years, you're cured. So 5 years is really a more important number, clinically speaking, and this trial looked at 5-year outcomes, and here's what the data is. On your left is the composite endpoint. You see a marked difference, 24% difference in absolute numbers in terms of primary endpoint. And here now, you see a difference in overall survival. If you look at the curve at 2 years, I told you there's no difference in survival. It's because we were here. So the benefits of the HeartMate 3 device in terms of survival happen after year 2. And importantly, the adverse event profile was very, very superior for the HeartMate 3. All the hemocompatibility-related adverse events, gastrointestinal bleeding, any stroke, pump thrombosis, and also cardiac arrhythmias were seen much less frequently in HeartMate 3. There was no adverse event where the HeartMate 2 was better than the HeartMate 3. So let's step back and look at what's happened at a 30,000 view of the corporate level MCS. So you better understanding what's happening in the field. Thoratec and hardware, the little fish in this diagram, were the companies that they made the hardware and HeartMate 2 devices originally. They got bought out by bigger fish, right? Thoratec was bought by St. Jude got bought by Abbott, and Medtronic bought hardware. And this is good for the field in one way, because now you have more money to spend more time, more money on research and development, creating more pumps. And what happened in 2021 is that Medtronic had to stop HVAD. And that was upsetting to many surgeons, particularly in Europe, because there were just too many strokes. There was increased mortality, and the pump sometimes would stop and we could not restart it, and people died because of that. So in June 2021, almost 3 years from today, there was one device only. What does that mean? You have a monopoly. So what are the realities of durable MCS as we stand here today? It is a monopoly. There's only one device you can use unless you're in a clinical trial, and we'll get to that in a second. So among us, there's a concern for a lack of motivation to advance technology, right? If you're making the only pumps in the market, why should I spend more time and more money developing something better when I don't need to, right? And that's always a concern in monopolies. The other thing that happened is the allocation scheme for donor organs changed in October 2018 that drastically favored temporary support, like the stuff that Steve and David spoke about, ECMO, balloon pumps, Impellas. It elevated those people to a higher status. And it disfavored durable LVAD support. So now you're status 4 if you're stable LVAD out of 6 statuses. So there's 3 statuses above you. We'll go back on this because it's such an important topic. But clearly, this is not helping durable MCS. when you're more likely to get a transplant if you have a balloon pump, ECMO, or Impella than if you have an LVAD. And also, in order for you to get up on that scale, you have to have a significant LVAD complication, bad infection, etc. So what's happened? BTT, although we don't use the label anymore, the indication has largely disappeared. We don't put devices for bridge to transplant, rarely. We use bridge to candidacy, what we call BTC, and people were not sure where they're going to go, but it's mostly a DT device now. The other thing that's happened in the field is growing clinical and academic interest in other stuff, mainly shock, and you heard Omar and others before me speak about it, because we're being so bad at shock, as Dave alluded to. Are we doing things wrong? I don't know the answer to that, but it's clear that we need to do something better. And the other topic is DCD, right? There's been an explosive excitement on harvesting and preservation of donor hearts, which is going to be the topic that Dave's going to be speaking about later. And the other thing is there's no new technologies that I can tell you are going to be around the corner. But in that regard, let me talk about what the pipeline looks like. There's the EVA heart. That's the only device that's now in clinical trials in the United States that I know of. It's a Japanese pump. It looks quite funny. You have a long inflow, which is never a good thing. The process device is, hey, it's here, right? It's being used. The experience in Japan has been very positive, and an asterisk of that because Japanese people look very different than us inside and out. And one good thing about this seems to be the incorporation of the inflow. You see the picture in your lower left. It seems to be a very nice incorporation of tissue around it. You don't get claw, you don't get fibrous ingrowth into it. The cons is you need a cool seal unit. What is that? That's a big machine that you see there. You have to drip water into the pump constantly to keep it cool and to elevate the bearing. So these are bulky peripherals. It's something that I don't think is gonna go well in this country. What else do we have? We have the TORVAD. The TORVAD is a device that has two pistons that generates a pulsatile flow. So we're going back to pulsatility, but with a small pump. And it's collected to an EKG so you can synchronize it with the cardiac cycle. And it runs at very low RPM, so it's going to be gentle on the blood. So that's one promising device. CoreWave is a French device that looks very much like the ones I've shown you, HeartMate 3. The different thing about the device is it's not a centrifuge, it's like a fishtail. So blood is propulsed like this. And I don't have, that's a movie, but you could see this. And the idea there is to be more gentle on the blood. It requires a driveline. It's been in preparation for years, and I'm not sure when this is going to become a reality. The Kalon is famous for being the smallest pump. I don't see any other meritorious aspects of the device other than that. Still has a driveline, still has batteries. The FineHeart is an interesting device. It's completely intraventricular. So there's one hole. You can put it minimally invasive through a small thoracotomy. You don't open the chest. You don't have to go bypass. And the inflow and outflow sit within the LVAD, left ventricle. The nice things here is synchronize the cardiac cycle. There's no drive line. Everything's inside. Corvian. Corvian is one that I like a lot. It's probably the most promising to me. It's tiny. It's very small, and it comes in a pediatric and an adult model. And it has an implantable battery. That looks pretty much like a pacemaker to you guys. It's something you put where you would put a pacemaker. It's thin. It's 30 millimeters thin. And it's charged wirelessly. Again, like the FineHeart. And you can run free for 3 hours without any connection. You can swim, you can bathe, you can do whatever you want, which you can't do with current technology. So this is promising. It runs at very, very low watts, 1.5 watts. And I think that's the reason they can transmit wirelessly. So this is a promising device, I think. And CH Biomedical, I only mention CH means China. That looks exactly the HeartMate 3 device. I'm not implying anything. And it is a fully magnetically levitated device, just a HeartMate 3. It's been approved in China. There's 100 implants for which we have zero data for, but we're told by the company it looks good. The only benefit I can see this device, if it proves to be as good as HeartMate 3, is it might be cheaper. And that's probably the closest device to an ID and a trial in the United States. Total artificial heart. I mentioned total artificial heart because apart from the HeartMate 3, it's the only device that's available in this country. This is an artificial heart. All right, this is really prehistoric. This was first put in a patient in 1985. It's 2 ventricles, 4 mechanical valves, held together with Velcro, literally. And it has these 2 hoses that come out of you that connect to a machine that pumps air in order to move diaphragms in here. Okay, this device has gone through 3 names. This is the Jarvik 7. I'm sure all of you have heard of the name of Jarvik. It became Cardio West TAH. Cardio West did one thing, which is create a smaller pump. This is 70 cc. They created a 50 cc, so smaller patients. But otherwise, it's the same look. If I stood here with this device in me, you could hear across the room, actually outside the room with the doors closed. So it is a noisy device, and it's not something that's really gained wide acceptance. There have been about 150 total artificial hearts placed in the United States since it first started. Thank you. The interesting thing, I have another device to show you. Does anybody know what this is? That's a breast implant. Why do I bring this in? When you put a total artificial heart, the small one, the pericardium constricts upon it and becomes very small. So when you have to do a transplant, all these are PTTs. This is not a destination therapy device. You have to take this out and do a transplant. The pericardium is so small that you can't fit a heart in. So what they do now is they put a breast implant next to the what we now call syncardia device. So I thought it was a cute thing to add in there. So are there new TAHs? Yes. The Bivacor is a very elegant device. It's a single rotor spinning 2 centrifugal pumps. It looks very good, and it's being studied in Texas as a possible replacement for the syncardia. The other device is a French device, a CARMAT, C-A-R, stands for Alain Carpentier, a famous cardiac surgeon. And this is his company. And this device has been implanted in 4 people, and the trials have been suspended for unclear reasons. The beauty about this device is it's for biological valves, no Coumadin, which is amazing. So other things that have happened in the field, this is called the Leviticus Wireless Coplanar Energy Transfer System. This is just a way of transmitting energy through the skin without connections. And I've shown you 2 technologies that are going to work. This is a different device that's actually being used clinically. And is used in 2 patients who had a Jarvik, and it basically consists of a coil, this thing here, that is put around your right lung. There's an internal battery here, and then you wear this thing that looks like a bra, so to speak, and which is the transmission belt, and you wear an external console and battery that charges this bra, and the bra transmits energy to the implanted battery, which then transmits energy to the coil, which transmits energy to the pump. Okay, well, kind of complex. And it's been successfully used in 2 patients. The company's trying to sell itself to another company, and there's been no interest. Now, let's go to that provocative part of the trial of the presentation is the issue of changing the conversation. I'm going to go back to the allocation scheme of 2018. If you see, before 2018, we had 3 statuses for LVAD transplants. You're 1A, highest priority, you're going to get a transplant soon. 1B, less so. 2, not so sick. And what happened, if you're a stable LVAD, you're 1B. Pretty good chance of getting a transplant. And if you got sick, you became a 1A, right? Dischargeable LVAD for 30. So you got 30 days free at 1A, then you went to 1B, and if you got sick, you became also 1A. If you had an MCS with threatening complications, arrhythmia, et cetera. What happened now, which is the new system, that same patient, the same stable LVAD is now status 4. Guess what? It's very hard to get your heart transplant now. So the pendulum is swung. It's swung favoring transplantation as opposed to LVAD. And it's swung tremendously because now you can put a balloon pump, you can put an Impella 5.5, you can put ECMO and bridge this patient and get him a heart quickly. And I think we're having imbalanced discussions when we talk to patients, particularly people who are obviously candidates for either one of those. And what happens? This is what happens. Typical conversations. Dr. Patel, Dr. Saeed go to the patient, hey, you're going to get a transplant. You're lucky. They say transplant is to heart failure what the lottery is to poverty, right? You're the one. You got chosen. LVAD is, you get him because you can't get a transplant. It's a less desirable choice. That's how it works. We emphasize survival. It almost seems like a panacea. You get a transplant. That's it. You're going to live forever. We rarely state that there's a 50% death rate at 12 years, right? So median survival is 12 years. And that's great. If you're 68-year-old, you get 12 years, you live to 80, that's great. If you're 32 and you live to 44, you have 50% chance dying, maybe that's not so good. And with LVADs, because until recently we didn't have the JAMA data, we failed to discuss median survival with any meaningfulness because we didn't have the data. we tend to minimize what bad things can happen after transplant, but we tell, oh, you can get right heart failure, you can get stroke, you drive down, you get infected, et cetera, et cetera. This is the biases we bring into the conversation. I'm pretty sure that we don't discuss the potential problems with immunosuppression, the 3 drugs you have to take sometimes twice a day. And here we underscore, you got to take your Coumadin, you got to check your INR every week, et cetera, et cetera. So what happens, patients outright refuse LVADs without a really deep understanding of benefit. So let's go a little bit about what happens after, potentially can happen after transplant. TR, up to 20% of people get TR, significant TR, either moderate or severe. 20% of patients after 9 years develop end-stage renal disease from calcineurin inhibition. PGD, primary graft dysfunction, 7.7% of them get it, and with a mortality of 41%. 20% of people require treatment for rejection, which prolongs lengths of stay or causes readmissions. 22% get readmitted within 30 days. Accelerated CAV within a year, 7% of patients. Those people have to be considered for retransplant, which is not an easy thing to get. Sudden cardiac death, 10% of transplants. Need for pacemaker, 5 to 10%. Do we sit down and tell the patients all these things when you say transplant? No, we don't. Cancer, that's a big one. 4 times more common in transplant patients than LVADs. Much greater metastatic potential if you get it. It is the second leading cause of mortality, late mortality. And it happens within 5 years, median time. And you can see there, over 10 years, 15% of patients will get a cancer. GI more common than skin, more common than heme. GI because this includes pediatrics as well, and adults it's skin first. When we were in ICLT in Colorado, this article came out. It's a New York Times editorial written by a famous author who had gotten 2 hearts. And I want to quote some things because they're really telling. And I invite you guys, just put on New York Times editorial heart transplant, it'll come up. Organ transplantation mired in stagnant science and antiquated, imprecise medicine that fails patients and organ donors. Over the almost 4 decades, a toxic triad of immunosuppressive medications has remained essentially the same with limited exceptions. These transplant drugs, which must be taken once or twice for life, cause secondary disease and dangerous conditions, including diabetes, high blood pressure, kidney damage and failure, serious infections, and cancers. The side effects of transplant immunosuppression can be sickening day to day. We talk about the vomit bags stashed in our purses, the anti-acid tablets we tuck in our front pockets for a quick nibble access at a cocktail party. My first donor heart died of transplant medicine's inadequate protection on my donor heart from rejection. The second one will die most likely from the stymied immune response that gave free rein to my cancer. She died 3 weeks after she wrote this article from metastatic breast cancer. So this brings to me the concept, and Steve has been asking sort of in an indirect way, this concept of net prolongation of life. Not can we get the patient out of the hospital and they're going to live a few years? How can we prolong life, particularly in young patients? So again, in most programs, tendencies to offer heart transplantation to young patients. And we had a debate session at ICLT, and the audience was asked, if we had a 30 patient, who would get an LVAD transplant? 80% said transplant. So this is there. That's the bias. The median survival is 11.5 years. If you live the first year, median survival is 13 years. Great. If you're 67, not so good if you're young. The chance of getting a second heart, and here's the thing, it's drastically reduced by, number one, you develop comorbidities secondary to chronic immunosuppression, obesity, renal dysfunction failure, cancer, you become non-compliant. So a lot of reasons for you not to be able to get a second heart. And in fact, the retransplantation rate in the United States is quite low. So should we be considering LVAD as the primary modality followed by heart transplantation in order to prolong patients' life? So I got to show you some data to try to support that. I'm going back to this. This is the overall survival. Remember I told you 2 years, there's no difference. In 5 years, there's a drastic difference in survival. Now let's take that top curve, right? The HeartMate 3, the green curve, and divide it into young versus old. Well, look at that. 5-year survival, if you're less than 50, is 74% in 5 years. So you don't hit median survival. Now let's take that curve, that top curve, and here's again, let's extrapolate what the median survival would be. And we did this statistically, 9.9 years. So I'm at 10-year median survival compared to an 11.5-year median survival. So transplant, which is what we have now. So now we're talking about same ball game. So I think this lends a lot of credence to started considering this sort of conversation with young patients. So the concept is the following, just to make it very clear. 35-year-old end-stage heart failure patient, you give them a heart, they have a 50% chance of living to 47. That means a 50% chance they're not going to make it to 47. But when you give them an LVAD, right now they have a young patient, they have almost a 10-year, these numbers are incorrect, 10 years survival, so they make it from 35 to 45. And then you get them a transplant. It's much easier to get a transplant after an LVAD than you after the first transplant. So you're adding 7 to 10 years to this person's life. So take-home messages, these are challenging times for durable LVAD. The allocation changes, the falling volumes, the lack of perceived progress. We don't have a wireless device yet, and the monopoly are really impacting the field. The pipeline is promising, but not around the corner. I think the next thing we're going to see is the heart rate is going to get smaller, the peripherals are going to get lighter. And the other thing is, I think we need to improve our communication with prospective patients when it comes to transplant versus LVAD. I thought you was going to be shameless. This Uli's paper and transcatheter device, and this is sort of what we're being able to accomplish in the trial. This paper just came out a couple of days ago. Dave's the senior author, and it's a DCD trial, Transmedics trial for DCD. And we just, a lot of people in this audience contribute to this, was the largest ever written book, 2-volume book on heart transplant, heart and lung transplant and MCS. And it's available on Amazon on pre-order right now. And finally, this, right? The 1-year transplant survival is 91%, ours is 96%. Thank you very much. Oh, we're way past time, so my apologies. Let's take a 5-minute break, bio break, and then we'll come back for the next session.
Andy,
Dave?
really quick, that was an outstanding review of where we are. Congratulations to you and Uli on your leadership. You guys have done more to move this field than just about anybody else, and that's really been gratifying to see. That was a very cogent argument you made. Let's see if you convinced the audience. So here's the question for the audience. You're going to die without either a transplant or a VAD. Who wants neither? Who would rather die? Raise your hand. Who wants a transplant? Who wants an LVAD? I think you did it.
Yes.
Well, we will redo this poll after Snehal speaks.
5 minutes, be back so we can get everybody out by noon.
You really need the moving picture or something. That was really inspiring.
Thank you.
That was amazing. Can you give me this slide of survival curves? How did you do that? How'd you make it?
I had Paul Newman do it for me. Paul Newman, he's a stats guy.
You probably just cover it.
Yeah, there's a slides guy, and you have it.
Amazing presentation.
Yeah, that's all right.
Ideally, we do it.
Sorry. When Sabrina is also here.
You guys have to tell us what you do.
Yeah, she did. She can.
Are we doing one or two?
Thanks for coming, ladies. Awesome.
I saw this. No cases in that? No. You can stay for my. Are you guys gonna stay or? Coming back. Coming back.
Hi. Oh. Good. Us?
Okay,
So it's Portel.
final round.
Portel's next,
Patel, right.
and then it's Omar. I'm looking for his last.
I can help you. It's on here. Yeah.
Is this one?
Yeah, HIV, yeah.
Okay, so this is for
And then is D'Alessandro who take us home.
Alexandro.
D'Alessandro,
Yeah,
yeah.
you had it up there already.
This one?
Yeah.
It was the second.
Let's see if that's the right one.
Oh,
This is the case.
No, it's this one.
This one right
Yeah,
here.
that's
Yes.
Oh, Christiana. Oh, it's Chilai.
Christiana
And
close.
then the last one, Chilai. Okay. Jelash, here. This one.
This one. Okay. So this one's they're not going right. Chavez.
And Travis, yeah, she's also on there. So it's the first one is Patel, the second one is the HIV Omar, then Chavez.
Okay, so then it's name of this one. This is done. This is done. This is done. Okay, so this is Portel. Then this is Dr. Omar, right?
Said, yeah, Omar Said, yeah.
And then this Chavez. And then
Alessandro, No Frontiers, this other talk.
the other side.
Is this the right one though? Let's just check.
Yes, this is the right one. This is the one that he did first. I'm gonna leave this one out here.
Okay.
And then
Jilash, this one.
George.
Okay.
And then
Great.
that's it?
Yep.
All right. Thank you, doctor.
Okay, thank you.
No problem, yes.
Sorry.
Yes.
No tiene mucho discípulo para juguetes.
You gonna help me?
Yes.
Okay.
Guys, move it along, okay? All right, someone ring the bells outside, bring people back in. Want to get started. By the way, who was here yesterday for the rosé? Good. Some, yeah. We went through 12 bottles, I heard.
You're on the panel.
Very quickly. Hey, Rox, can you go into the room, drag people back? All right, we're going to get started. You just heard a state-of-the-art review of transplant LVADs. And now it's my pleasure to introduce Nihal Patel, who is the director of our transplant program. A great colleague and friend, a really another out-of-box thinker, who's going to talk to us about the state of our heart transplantation 2023. Snehal.
So thanks, Danny, for two things. One, having me up here today, and two, for giving that incredible talk about the benefits of LVAD and asking me to follow it with transplant. I was supplied a beginning rebuttal was that Amy Silverstein from the New York Times editorial, she got a transplant and she lived 35 years. You know, so there is still hope for this therapy, and I'm gonna go ahead and get started here. So, like Danny, I've been giving some version of this talk about heart transplant in 2020, heart transplant in the last couple of years here. It's generally been an overview of transplant, kind of a heart transplant 101, and I wanted to do something a little bit different. So I looked for inspiration at the title that Dr. Yordi gave me, which was Heart Transplant in 2023, State of the Art. I don't have any disclosures. And I think when most of us think about state of the art in 2023, we think about ChatGPT, correct? So I went to ChatGPT. I hadn't really been in there. I made a login and I put in heart transplant state of the art 2023. And this was the response that was generated. A couple of important things that I want to point out. Number one, and I didn't realize this, that the knowledge cutoff for ChatGPT is September 2021. So it's not actually fully state of the art, maybe about a year and a half old, but I think it's still useful. Oh, is that correct? Yeah, I think you have to pay for that version though. Yeah. And then when you look at the topics that came up, they're actually quite relevant and very good. A lot of the stuff I would have gone over: donor selection, immunosuppression, rejection, preservation, biomarkers, and artificial hearts. And I thought, great, here's my talk. I'll be done in 5 minutes. And then I also realized everybody could just go to ChatGPT and get that talk. So I wanted to do something a little different, a little bit more unique. So I took the liberty of changing this a little bit to talk particularly about the Montefiore heart transplant program and what we're doing in 2023 to be state of the art. And whenever you think about a big academic medical program, we really look at it through the lens of these four things, and that's clinical care, academics, education, and community. So over the next 20 minutes or so, I want to take you guys through these four things. So starting with clinical care, right here, we're really talking about what are we doing to impact the individuals that are under our care, our heart transplant recipients. And before we go into that, we really have to understand what's the goal of heart transplant. So we're taking patients like this that have days to weeks, maybe even up to a month or 6 months to live, and we're offering them quantity of life. This is data from the International Society of Heart Lung Transplant Registry, almost 130,000 patients. Danny already presented this. You can see that the median survival is 11 years. So we're taking people on death's doorstep and giving them 11 years of survival. And it's not just the quantity of life, it's also quality of life. There's a lot of data on this after transplant. This is a simple look in the red bars that says which patients after transplant have no activity limitations. And you can see at 1, 3, and 5 years, more than 90% of patients have no activity limitation. So really great therapy offering quantity and quality of life for people that are imminent to die, and really something I think that has almost no parallel in medicine. But this is something that Danny pointed out, and something that we think about a lot too, is that this therapy is not perfect. There's a high burden and intensity of care after heart transplantation. This, for example, is a medication list that we send our patients home with after transplant. 15 to 20 medications, many of them that they have to take 1, 2, 3 times a day. And we're constantly worried about rejection, organ transplantation. So we have to do endomyocardial biopsies, an invasive procedure surveilling for transplant. And this is a biopsy schedule in the first year from one of our patients. And you can see that this is 14 biopsies in the first year. So this is a burden and reduces patient quality of life. So what we've been thinking here in our heart transplant, sorry, let me just go back one step, is that I also want to add, and Danny pointed this out, is that this therapy has been around for 40 years, but while we made some improvements in survival, they've actually been minimal. This is survival by decade. Blue is the 1980s, green is the 90s, red is the early 2000s, and purple is 2010. So we've made some survival, but we really haven't moved the curve that much. And importantly, with the median survival of 11 years, a younger patient, this doesn't represent a cure. And I think we heard about that very clearly in the last talk. So what we've been thinking a lot about at our program is, how can we reduce the burden of care while improving on long-term risks and outcomes? And the way that we think about that here is look at the complications of heart transplantation. And we split them into those early in the peri-op period and those that occur later after transplantation. And the dreaded early complication, the one that affects mortality the most, is primary graft dysfunction. So what is primary graft dysfunction? It's the leading cause of early mortality after transplant. And it happens because at each step of the transplant process, including from brain death in the donor to transportation to taking the clamp off and being reperfused with the hormone and metabolism of the recipients, the donor heart is subjected to repeated insults. And in its severe form, PGD leads to severe biventricular dysfunction requiring ECMO to support the circulation. While many of these patients recover their heart function over time, it actually comes with quite a penalty. So this is a nice study out of the University of Pittsburgh looking at almost 450 patients, and they found that the overall incidence of PGD was 16.5%. Importantly, it came with a penalty. So blue is the patients that had no PGD, red is the patients that had PGD, and you can see a big upfront risk for mortality. That was 32% of patients with PGD didn't leave the hospital. What they did next, which I think is interesting, is they looked at the risk factors for PGD, and they found that ischemic time was the largest risk factor. So every 10-minute increase in ischemic time was associated with the 5% greater odds of primary graft dysfunction. So what's ischemic time? Well, that's the cold ischemia of the donor heart during the transplant process. Remember, when the heart is recovered from the donor, it undergoes cardioplegia, and then it's basically stuck in a bag in an igloo cooler just to freeze the heart until it is surgically reimplanted in the recipient and the clamps are taken off and it's perfused again. So how can we, this ischemia, while it's been around for 40 or 50 years, is actually a problem. And we're starting to understand this more, that the gold target temperature for heart storage is 2 to 4 degrees Celsius. And this is based on preclinical studies. However, when they looked at this in a recent study, they found that average organ temperature during cooler transplantation often fell below 2 degrees Celsius, and many times, especially if the heart was on ice for a long time, fell below 0 degrees Celsius. And this is a problem because there's known risks below 2 degrees Celsius. At less than 2 degrees, there's cold injury. At less than 1 degree, there's irreversible suppression of diastolic function. And at less than 0 degrees, we start seeing destruction of all the proteins. So something that is a really simple concept that we started utilizing the last year is this, the Sherpa pack, which is produced by a company, Cardiogenic. You can basically think of it as a thermos to put the heart in, and it maintains a steady temperature of 2 to 4 degrees. And while this isn't a huge technological advance, it actually works quite well. So we've started using this almost regularly on all our recoveries for heart transplantation. Another way to address the issue of cold ischemia is with machine perfusion. So what if we could take the heart out of the recipient and put it on a machine that actually perfuses it with oxygenated blood? It sounds a little bit like science fiction, but a company, Transmedics, which is based in Massachusetts, developed the organ care system, which is known as the Heart in the Box. This is a cartoon of the heart in the box. The heart sits here. There's a chemical reservoir for additives. There's the pump to pump blood through, and this is what it looks like in real life. This is a picture of one of our first runs of the heart in the box with the heart actually beating, and this is an image provided from the company with everything exposed, and you can see really well how well this heart is perfused and that it's pumping. So over the last year and a half, we've really been looking at perfusion injury. And in 2022, 2023, you can see that this is just for donation after brain death. We used the organ care system 4 times, the Sherpa pack 17 times, and went with traditional ice storage only 14 times. And this looks at our primary graft failure rate by year. And you can see with the institution of this, we've decreased this significantly from 23% of patients in 2020 to down to 3% in the past year and a half. The other thing that we've been looking at is complications late after heart transplantation. The one that we're worried about most is obviously rejection in solid organ transplantation. The body is going to recognize the donor heart as a foreign object and try to attack it. So we use immunosuppression to prevent that. And this is associated with a host of complications. Danny pointed this out elegantly in his slide. I've summarized these here. They include infection, renal dysfunction, metabolic disorders, osteoporosis, malignancy, and cardiac allograft vasculopathy. And these are all really due to the toxic effects of immunosuppression that we give our patients. One of my mentors and a leading heart failure cardiologist in the world will often refer to immunosuppression as poison. And that's true. And it brings up the concept that are we actually helicopter managing our transplant patients? We're so focused on rejection, we're doing too many biopsies, we're giving them too much immunosuppression. And why do I say that? Well, if you look at rates of rejection over the past 20 years or so, you'll see that they're decreasing to the point we have to start thinking, are we overdoing it? Has the pendulum swung too far the other way? So how are we addressing this here at Montefiore? Two things. One, we're transitioning away from invasive biopsies to non-invasive liquid biopsies. And we're really looking at precision medicine to tailor the care for each of our patients rather than a one-size-fits-all approach. This is the liquid biopsy. Cristiana Spinola, who is our lead transplant coordinator, is going to go over this. So I'm not going to go into it so much, but let me just say that we've largely abandoned surveillance biopsies for this non-invasive method. And importantly, during our management of immunosuppression, we've about to start this mosaic study that has three important objectives that I think are critical for the transplant field moving forward. One is we're objectively risk stratifying these patients for their risk of rejection using molecular biomarkers. And the second point is probably the most important, is that we're accelerating minimization of CNI, which is calcineurin inhibitors, or the mainstay of immunosuppression. And we're also able to reduce the number of surveillance EMBs. This is the study. It's a one-to-one randomization, so a real trial of 900 plus patients. And what I want to point out is that the national principal investigator for this is our own Dr. Yordi, and it really just shows how we're pushing the field to improve constantly. The other thing that I want to mention is coronary allograft vasculopathy. This is an accelerated proliferation of the intimal vasculature of the transplanted heart. You can see the diagram over here on the right. It's a leading cause of late post-transplant mortality. Remember, these hearts that after the transplant process are denervated, so they're asymptomatic, they don't feel angina. And what we need to do is we need to actually look for it before it actually causes problems. And the standard of care is to do invasive coronary angiographies. We do these yearly. But in many ways, this is a reactive approach because we're looking for epicardial disease after it's already happened, looking to stent it. So we want to take a proactive approach. And what a lot of people have done is they've used IVUS to look for intimal thickening. And we've decided to take it one step further. So our cath lab here, our interventionalists are some of the leaders in optical coherence tomography. This is OCT. It's an intracoronary imaging modality that actually offers better plaque characterization than IVUS. So what we've done is at baseline after transplantation, between 6 and 8 weeks, everybody gets a baseline OCT, and we stratify them based on risk into normal looking coronary arteries, homogeneous intimal thickening, in what we've termed advanced plaque characteristics. These are nice images from our patients. These are representative images of all the different things that we can pick up on OCT. And our initial experience with OCT, you can see we looked at 63 heart transplant recipients. We ended up having 35 that underwent baseline OCT. And we found a number of different morphologies of their intima when we did these baseline OCTs. And when we stratified them for clinical events, namely death, heart failure, or advanced coronary allograft vasculopathy, we saw that this actually provided excellent risk stratification. I want to show you how this can work in real life with one of our representative cases. So this is a baseline angiogram, which basically shows normal coronary arteries. At years 3 and 5, you can start seeing the development of a mid-LAD lesion that becomes significant by year 3. Now, wouldn't it be great if at baseline we could have predicted that this was going to happen to that patient? Well, this is this patient's baseline OCT in at 1 year, and you can see that there's homogeneous intimal thickening here. And this is kind of a layered plaque feature of the intima at 1 year. So this allows us the opportunity to actually start tailoring our therapy. And that's going to be the next step of what we do, where we really personalize our approach based on these OCT findings when we think about who needs dual antiplatelets, who needs change of their immunosuppression. And this is kind of the next phase, and hopefully next year you'll see the results of our program with that. The next thing that I'd like to talk about is academics. So how are we contributing to academics at Montefiore? And this is how are we impacting the epidemiology of the transplant community at large? And one of the big things that we focused on is donor availability. So just to take a step back, these are the number of transplants that have been done in the country year over year. It's about 3,500. There's been a small bump starting in the 2000 for a variety of reasons, most importantly because of the opioid epidemic in our country. And we're not doing more transplants, not because there's not more recipients, but because there's not enough donors available. And if you think about the fact that there's over 200,000 individuals in the United States who have advanced heart failure that could benefit from transplant, we're left with a big supply-demand mismatch. So there's really two ways that you can expand the donor pool. The first is to increase the number of organs that are available through public health policy initiatives, get more people to sign up. But something that's within our hands is increasing the recovery rate. So right now, only 1 of 3 hearts that's offered is actually placed for transplantation. And while many times that's reasonable, the hearts are older, they have atherosclerotic disease, a lot of the times we just don't know what's acceptable or not. There's no evidence for this. So we started addressing this about 7 years ago. Dr. Madan, who's in our group, has really been the one that's spearheading this. We looked at donor troponin. Initially, we would often turn down hearts if the troponin was elevated, even if the ejection fraction was okay. In a large database, we found that as long as the heart looked okay, the donor troponin had no impact on recipient mortality. Probably one of the biggest contributions we've had is this publication from Dr. Madan and Dr. Yordi looking at left ventricular systolic dysfunction after brain death. That's quite common and reverses over time. We were never really certain whether that was okay to take these hearts. In a big analysis, what they found was there was no difference between normal hearts and those with improving systolic dysfunction. And what's come out of this is a recovery protocol that they proposed at the end of this paper that I think is widely used right now in assessing donor hearts for acceptability. A couple of other things that I want to mention. We were leaders in using hepatitis C donors. So for a long time, as you guys know, 15, 20 years ago, Hep C was a death sentence. There was no treatment for it. It's just recent, and because of that, and the fact that it's so contagious, we would automatically say no to hearts with hepatitis C. We were one of the first centers to start looking at this. We had a publication on this. And with the management strategy of if they develop viremia, actually treating it, we've shown excellent outcomes. And it's a regular part of our donor assessment and acceptance practices at this point. The last thing I'm not going to mention too much because Dr. D'Alessandro is going to go over, and this is donation after circulatory death. This is when potential donors are only made donors after death is declared because of circulatory arrest, and this is different than standard brain death. Last year, Dr. Madan had a publication in JACC that looked at the feasibility and potential impact of heart transplant in DCD. You could see that there was no difference at 6 months between DCD and DBD donors. And probably the most important thing in this publication was looking at how we could potentially improve the number of donors that's available. So over time, up until 2020, there's been a huge increase in the number of DCD donors that were offered for transplant. So in 2020, there were 3,000 donors that were offered for transplant. And if you think about this, and if we stick to that acceptance rate of 1 in 3, we're talking about 1,000 more donors per year in this country. So I'm going to skip over education because that's kind of the purpose of what we're doing here right now. And for the interest of time, I just want to finish up a little bit on community. As we all know, Montefiore is in the Bronx. This is a unique area. There's 1.4 million residents that live in the Bronx. And we have a diverse and minority population, 56% Hispanic, 30% Black, and only 8.8% white. Maybe even more importantly, the Bronx County is the poorest congressional district in the United States, not one of the poorest, the actual poorest. And 26% of patients live in poverty in the Bronx. So our patients here have 2 strikes against them, 1 minority and 2 a socioeconomic distressed population. Across all of medical care, these populations do poorly. And transplant's no different. When this is an assessment, this is a paper that came out in Lancet last year that looked at race as an impact on outcomes after transplantation. What they found was that Black patients in blue compared to white patients in red, after they were listed for transplant, waited longer for transplant. If they were delisted, they were less likely to be relisted. And in a different publication, and this has been replicated many times, if Black patients got transplanted, they tended to do worse. So what are we doing about it? A common theme amongst our team is that we don't run from the Bronx. We really serve our patients, and this is one of the things that I'm most proud of. This is SRTR data. This is publicly available. If anybody has a patient that they want to refer, I encourage them to tell them to go look at srtr.org. It shows all different stuff about our transplant program, including who we're transplanting. So here's our wait list registration on the right as of June. I want to point out a couple of things. Our population is composed of 23% white, 38% Black, and 30% Hispanic. And look at that compared to our region, which is New York, and the country as a whole. We really serve a minority population. And not only do we serve it, I think we do it well with quantity and quality. This is the number of transplants that's done per year on average, just to give you a sense of what's a big program and what's a large program. So there's about 130 programs across North America. And you see that the number of programs that are doing more than 40 transplants per year is very small. And these are our numbers for transplants over the last 7 years. You can see we've had a large increase with over 40 transplants per year. And last year, we had a particularly complex patient mix with 10 combined dual organs, 16 DCD. Dr. Saeed is going to talk about the first in world HIV to HIV transplantation. And when you put this all together, we don't just do it with quantity, we do it with quality. Dr. Goldstein just showed this, Dr. Yordi mentioned it, that we have 95.74% 1-year survival. And this graph here shows going left to right, the number, each dot represents an individual transplant program. Going left to right means the number of transplants, so the right means you've done more. And up means you've done worse than expected, and down means you've done better than expected. And you can see, so we really want to be as in this corner, doing a lot of transplants and doing it with better than expected survival. And we're one of the few programs that's down here. So with that, I'm going to stop and I'm going to conclude that the Montefiore heart transplant program is state-of-the-art in 2023. And we've done this by clinically focusing on individual outcomes to overcome the traditional barriers to success. Academically, we're really focused on expanding the donor pool, and we've been really dedicated to our community. You've seen this picture a few times. This is our team. I want to thank them because it's not just the physicians, it's our social workers, transplant and LVAD coordinators, dietitians, administrators, everybody's contributed. And in particular, these two guys who are my mentors and have really empowered the team to be successful in every each way. So I'm going to stop there.
Thank you so much, Sneha. The next presentation, if we have any questions from the floor.
Some commentary.
Yeah. Let me just make a commentary first to Snehal Patel, who has taken over the transplant program, I think about 3 years ago, in the middle of the COVID epidemic when we were pretty much a disaster hospital. And we now looked at the data that he just showed that came out under his leadership. And these are the best data Montefiore has ever had. And I think they are probably top 3% in the nation. So Snehal, thank you for your leadership.
Those are outstanding results. You all should be very proud of yourselves. I was the 3rd surgical director of this transplant program, so I feel like I deserve some of that credit. But everyone in this room that works in some capacity at Montefiore is responsible for those results. We all know in transplant that this is a team effort. You have a particularly challenging population, as you just pointed out, and to be able to achieve those outcomes means that the entire machine is working well. No part of it is at fault. It's a great team. Congratulations.
I'm going to prepare the next presentation. Omar. Okay.
Yep.
There.
Thank you. Great talk, Snehal. That was very good to see all that information. So I'm going to talk about something that was done first time in the world here at Montefiore. An incredibly unique case that was a privilege to be part of the whole team. So this was a 62-year-old woman with an ischemic cardiomyopathy on peritoneal dialysis. I was seeing her in the heart failure clinic. She was already listed for kidney transplantation, but while on the kidney transplant list, her LV function has started to decline from 40%, which is an acceptable cutoff just to get a kidney only, to 25%. We looked at her coronary angiogram. She had some stenosis in the LAD. She was actually stented. But despite doing stenting and PCI, her LV function did not improve. And at that point, she was no longer eligible for just kidney only because of dual organ dysfunction. Her other medical history was she had a history of HIV, which she had contracted many decades ago, but was compliant with her enteroretroviral therapy, and her CD4 count was okay. It was 356. She had an undetectable viral load and no history of any opportunistic infections. She was on this ARV regimen. There was no prior history of resistance. She had a history of renal cancer in the past, had actually undergone a nephrectomy back in 2006, and was currently had end-stage renal disease from this FSGS diagnosis, which was related to HIV. She was a blood group O. And after looking at all this information, her only pathway to transplantation was dual organ. And these were acceptable criteria otherwise. So we listed her as a UNO status 5 for a dual organ heart kidney potential transplant. So what happened then? Unfortunately, she had no offers that were suitable to her. She waited for 6 months, no offers. And in the process, she had an awful quality of life, a lot of fatigue, exhaustion. She was getting peritoneal dialysis, not doing well, just very frustrated. And we looked at her hemodynamics, and they were not permissible to a UNO status upgrade. I want to take a step back a little bit about to summarize transplantation in patients that are HIV positive. So HIV negative, so donors that don't have HIV, to HIV positive heart transplantation has been around for over 2 decades, but you can see the numbers here, they're low, right? Not a lot of patients even now have received, not a lot of patients with HIV have received heart transplantation. A recent report, the graph on the right, looked at 75 such patients, but their outcomes are okay. They're similar to the patients who don't have HIV, the recipients. Of course, these patients are selected, and so there's a bias there. But even in those that are selected for transplantation, tend to do okay. But what about taking donors with HIV and transplanting them into HIV positive recipients? So the first experience, there was a first report back in 2003, and it was in South Africa. From that point on, this was in kidney. They did more of these HIV positive donors over time, and they reported their experience of 27 such patients in just kidney transplantation, and these are the outcomes. So the graft survival of the transplanted kidney, as well as the patient survival, were acceptable. These are on par with taking donors that are not HIV. So there was a lot of confidence from this data that this sort of thing can be done and potentially in other organs. So based on that, there was the HOPE Act that was signed here in the United States back into 2013. And under this, patients were permissible to have transplantation from HIV positive donors under research protocols. But for a program to be eligible for that specific organ, they had to have done already 5 HIV negative to positive transplants for that organ to move forward. So what is the data here in the US under this HOPE framework? So this is data from Dr. Duran, who leads that. So this is in kidney. So the outcomes of taking HIV positive donors and transplanting them into HIV positive patients, that's the blue line, versus the control in the black. So the graft survival here under HOPE for kidney is similar. The rejection-free survival seems to be a little bit, at least numerically reduced, although it didn't reach statistical significance. And there's many hypotheses what that may be. It may be differences in immunosuppression, perhaps more infection causing lower immunosuppression and eventually leading to more rejection. But that needs to be sorted. Either way, the survival of the graft, though, it seems to be equivalent in kidney. Information is also available from liver transplantation under HOPE, and these are the outcomes. So, it sticks out to me was the blue curves were a little bit worse than the black curves. On the other hand, this is still much better than the survival without transplantation. Like, there's just no question about that. So I think more data is needed here, but still, this is not prohibitive by any means, and it's still being done. So we have data in kidney, we have data in liver, But what about heart transplantation? So that's where our donor, our recipient actually comes into play. And we looked at all this information, for these other organs. And it turned out that because Montefiore has a rich history of a lot of experience in managing patients with HIV, heart transplanting patients that have HIV. So we had done actually 4 of these already when our recipient was listed. And there was another member of the infectious disease team, which is of course very closely involved in all this, that had an experience from a different center. And overall, we were eligible to perform heart transplantation and take an HIV positive donor for our recipient potentially. And in the ones that we have done, these are now HIV positive recipients, they've all done well, right? They've all alive after 1 year, had no HIV complications. So that's further experience. And, I think over here, the ID team is exceptional and they have a lot of experience in managing HIV. And our entire team, along with the surgeons and the critical care doctors and our heart failure team, we all work really closely well together. I think you see some of that here in the meeting. So that further gave us confidence that we could do this sort of thing. So that was there. One other thing I want to show, this is recent data. So what happens to patients that are status 5? So Dr. Goldstein mentioned all the different priority statuses. You would think that if somebody, the status would predict their mortality, right? If somebody has the highest status, they ought to have a highest mortality on the wait list. And that's why they got the highest status, because they have the high risk of dying. The thing is that this breaks down if you're status 5. So these are survival curves. So the patients that are status 5, so they're a lower priority, actually have a lower survival than those patients that are status 3 and 4. So this is a little bit of an issue. And this, I think, has to do with the fact that they need 2 organs. And so they're actually sicker, but their hemodynamics don't allow them to be at a higher priority status, even though they have lower survival on the wait list. And our recipient was in this situation. So we discussed all this with her. And ultimately, she was also extremely frustrated with her quality of life. She agreed to consent under the whole framework to receive a HIV positive donor. Within 1 week of doing that, there was actually a donor available that was suitable for her. And we accepted the organ. This just briefly was a young donor who unfortunately had an accident, motor vehicle accident, and had intracranial hemorrhage, and progressed to brain death. The donor had a recent diagnosis of HIV, was reportedly adherent to her antiretrovirals. The CD4 count at the time was unknown. The viral load was undetectable, and she had not had any history of opportunistic infections. Because of the ischemic time, we used the OCS system Dr. Patel had mentioned for this transplantation. And after transplant, the patient was actually managed with our routine protocol, which was induction by basiliximab, because she had also received a kidney transplant, and the usual immunosuppression and prophylactic medications. So the transplantation was performed. Dr. Borgi performed the heart transplant. And afterwards, this is again an example of how closely the team has to work together, because transplant surgery is part of the process. But afterwards in the ICU, the patient did have some complications. She had developed septic shock from serratia and severe pneumonia, actually had required tracheostomy. And the kidney transplant initially did not work well, and then she needed temporary dialysis. You can see all the blue circles. These are the different infections she developed over time. But with very close management, again, by our infectious disease colleagues, we were able to get her through this difficult perioperative period. Ultimately, the patient was discharged to rehab, and now over a year after this has been performed, she actually is thriving and doing really well. So this was clearly a success, remains a success for us. But what are the barriers for trying to do this even more often? So if you look at the HOPE data, the numbers of transplants are actually lower than expected in in liver and kidney, and the heart is the only case that we did here. So these authors looked at how can they increase that, right? So for heart transplantation, there's about 148 programs that perform it. Right now, based on the eligibility criteria, you had to have done 5 prior ones in negative to positive patients. Only 2 programs are eligible to move forward, ours being one of them. But what if you reduce that level of experience? So if you do that to 1 or 3, you can see that that increases the number of centers that will be eligible to perform this. I mean, this is under review. by the federal committees, and we'll see what happens with the requirement. So ultimately, the takeaway from this case, this required a lot of internal teamwork with the many different services that work together very closely here. External teamwork with the HOPE team, because this was done under the research protocol. And in the future, like I said, there's a policy under review to see if that requirement of 5 is going to change. And I think more centers multi-center studies will be needed to look at the outcomes of these patients. Thank you so much. I want to obviously acknowledge the patient. She's in red, there in the red shirt. She an incredible person and very brave to go through this, and she's doing really well. She's with her husband there. And of course, the donor, that's the donor's mom in the picture. We had a reunion of the donor and the recipient here, and it was incredible to be part of that. Thank you.
Omar, thank you so much. I have a question regarding the immunosuppression regime. Traditionally, with antiviral medication, you used to have problems. Can you comment on that? Whether you had any problems? I know with the current regimes, it's not such an issue, and the importance of having a pharmacist on a transplant team.
Yeah, great question. And so there is the most common drug-drug interaction we wanted to confirm. So one of the HIV medications, ritonavir, it can actually have a drug interaction with tacrolimus. So we had to make sure that our recipient was not on that medication. That's just one example. But definitely there was a lot of attention paid with our pharmacist, Daryl, who's our transplant pharmacist, him, along with Dr. Daryl right there, and the ID team, Dr. Hemidge and his group, to make sure that there would be no drug interactions between the HIV medications and the immunosuppressants afterwards.
Omar, sorry.
So one comment, one question. One, I didn't realize you were in the room when Obama signed it into law to take that picture. And two, what about the possibility of HIV positive recipient to HIV negative donor? Would you take that? I know we're not there yet, but.
Yeah, we're not. I think it is a possibility in the future, depending on the specific scenario. If otherwise the recipient was, at imminent death, in the current era of ARVs and their effectiveness, it doesn't sound like a crazy idea. But this sort of thing has to be done with a lot of review from ethics and potentially under a research protocol, but would be a possibility.
I was going to ask that question as well, but in addition to that, why has it taken so long? Like, why was this so out of the box? The donor's viral load is undetectable, theoretically should not be infectious, and the recipient already has HIV, so you're going to treat them anyway. So what difference does it make whether the donor has or doesn't have HIV, as long as the graft is otherwise good?
Yeah, based on all the points you said, so based on that, it should have already been done. But I think this field moves slow. There's fear of the unknown, which, like you said, dig into the details may not be that bad. There's many barriers, just some of that based on just maybe not logical fear. But I think now that we've started the process, hopefully it will lead to more of these cases being done.
Yeah, there are some bureaucratic barriers. I'm not going to give a long answer, but I encourage you to read the editorial that Dr. Madan and I have written in JHLT, which is entitled Science Won, Bias Remains. That's the answer.
Okay, so we move on. Next presentation by Patricia Chavez on heart transplant sickle cell.
Yes, thank you very much. Good morning, everybody. So we're gonna discuss a case, a very unique case that was performed here. And I hope to get also your participation along it. So this was a 33-year-old female, African-American, with history of sickle cell beta thalassemia plus, that presented with 3 months prior diagnosis of peripartum cardiomyopathy right after a C-section in the setting of severe preeclampsia. At the time when she was diagnosed, she was placed on minimal medical therapy. And 3 months later, she comes to us with cough and shortness of breath, hypoxic in the emergency room with acute respiratory failure, confirmed by X-ray, clinical exam, crashing from the respiratory status in the emergency room. Further workup showed evidence of hemolysis by a high LDH, high free hemoglobin, and a low haptoglobin, a low hemoglobin lower to her baseline, thrombocytopenia, and a high red tick count, and also evidence of end organ dysfunction with a high lactic acid and elevated creatinine. And on the smear, we found schistocytes, which are compatible with vaso-occlusive crisis. Immediately after she was placed on BiPAP, she didn't tolerate for too long and had to be intubated. And because of the findings above, she was placed on dobutamine and was taken to the lab to assess her hemodynamics. She was tachycardic with a borderline blood pressure despite inotropic support and had biventricular elevated filling pressures with a very low index up to 1.6. So now you have a patient with acute respiratory failure, already intubated, with profound cardiogenic shock and evidence of hemolysis. Would you place this patient with underlying sickle cell disease on mechanical support like ECMO? Can you raise hands? Who would?
I'm going to jump by 5. Put there anyway. She's a small end. Small lady, small end.
One question, did you give bromocriptine?
No, she did not get it at the time of diagnosis, no. This was an outside hospital diagnosis, and she just presented to us at that moment, but she did not get it as soon as she came in, no.
Okay. Yeah, I mean, if she's dying, I probably put it in the ECMO.
What about the audience? Could you raise hands who would put this patient on ECMO? 3 believers. Who wouldn't? Okay. So just to put in perspective, I just want to emphasize what is the overlap that happens in such a particular patient from the hematologic perspective, in addition to having a profound cardiac issue. So what is the overlap between a vaso-occlusive crisis and cardiogenic shock? A vaso-occlusive crisis starts with hypoxia, which affects the hemoglobin S, which is fetal hemoglobin that should not be present in an adult, but is predominant in a patient with sickle cell disease. And that is going to lead to hemoglobin deoxygenation, which end up polymerizing the hemoglobin S. And the result is what we see under the microscope that helps us identify a crisis, which is red blood cell sickling, with ensuing hemolysis that ends up damaging the endothelium and causes endothelial dysfunction. And that contributes to a systemic inflammation, which perpetuates this cycle of hypoxia. And what we see in cardiogenic shock is that the myocardial ischemia, whether chronic or acute, will lead to hypoperfusion that crosses over to this cycle of hypoxia that leads again to endothelial dysfunction and causes inflammation. So both pathophysiologies cross paths and they overlap and perpetuate each other as time goes. So what happened to our patient is that, as I said, she was on BiPAP, she required inotropes, she ended up being intubated with profound cardiogenic shock, and she did end up undergoing VA ECMO cannulation, only with inotropic support for venting because she didn't meet any criteria for any additional support. But with VA ECMO, as we know, there are concern for hemolysis, which this patient already has an ongoing hemolysis process from her inherited hematological disorder. And that led us to use red cell exchange transfusion to be able to correct this hematological profile and allow for stability under the circuit. Within 6 days of placing ECMO, she was successfully decannulated. But then she declared herself as what we already suspected, a patient with end-stage heart failure. that became inotrope dependent. So now that you have a young female that we saved her from death door with stage 3 heart failure with this underlying sickle cell disease, would you consider her for transplant?
Maybe just, Patricia, you can take a step back and also, point out that the two concerns are, is her lifespan going to be abbreviated because of the sickle cell disease? The second risk of patients going on cardiopulmonary bypass for sickle cell disease, correct?
Yes, so this is actually what the concern was. But first, can a sickle cell patient become a transplant candidate? Like, is there something written on the guidelines, being this a rare disorder? And this is actually not addressed. We know that there's the guidelines, at least from 2016, they describe how a patient can become a candidate based on certain parameters regarding age, obesity, and other factors that we know for sure. And the only update that they had in 2016 was based on frailty and mechanical support to candidacy. But as you mentioned, there's additional risk factors that come with a heart transplant and this underlying condition. So if we look at the literature, what did we see? So there's only actually 4 cases of sickle cell, either disease or trade, that have been published in the literature for transplantation. 2 of them for heart alone, 1 for heart lung and 1 for heart kidney, and 2 of them diseased immediately after because of these complications from hemolysis and cardiopulmonary bypass immediately post-transplant, and only 2 of them alive.
So those are terrible outcomes. How would that encourage you to transplant? I said those are terrible outcomes. I think we all agree. So how would that encourage you to want to transplant this patient?
Well, this is exactly what I'm getting to now. So the risk for the two main things that we have to think about here is what is the risk of crisis with transplant, and what is also the graft survival, where that is impacted, and what are the factors for that. So the risk of crisis has to do with the cardiopulmonary bypass, which is usually with low temperatures. So the cases that were actually alive had evidence that they use normothermia. And there's additional cases in the literature for cabbage, particularly, that have used normothermia successfully in these patients, because as we saw before, normothermia can lead to hypoxia, and then hypoxia will end up leading to a full vaso-occlusive crisis. There's also an alloimmunization prophylaxis that we need to take into account, because these patients are going to be transplanted multiple times, transfused multiple times in the past, and they may have antibodies that maybe make them incompatible or at risk of developing a crisis in itself. And the other factor to take into account is that this hemoglobin S that is predominant in patients with sickle cell disease needs to be lowered to an adequate level that will allow normal hemoglobin to be able to carry the oxygen and allow for the perfusion of the organ. So from literature review, we also know that there's no set number as of where should we bring this percentage. Some cases for the cardiopulmonary bypass under cabbage describe that 30% is enough, but we decided to set up a lower level, trying to promote the perfusion for the organ as much as we could. And the graft survival is also important, as Dr. Patel hinted earlier, because we need to understand really well what's the prognosis of this disease. So, and this taking a step back into what sickle cell is, so it's an inherited disorder with autosomal dominance a pattern that is actually classified at least into 4 categories and 4 subtypes. And of those, we know that particularly sickle cell beta thalassemia plus has a pretty good prognosis. These patients are described to have crisis early on in childhood, but over the years, they actually have minimal evidence of crisis, and they live with a relatively normal hemoglobin over time. So this is what helped us decide that even though she had this hematological disorder and as an underlying condition, her prognosis was overall appropriate. It was overall good. So we had a chance to offer her a therapy like this. And as I mentioned, the vaso-occlusive crisis recurrence is actually low in this particular group of patients with sickle cell disease. So what happened to our patient? So she, as a stage D heart failure patient, after ECMO, she had more complications related to ECMO cannulations, such as a pulmonary embolism and infarct, and developed frailty, for which she needed to stay in the hospital for about 30 days. And this was very challenging because we had to work with, she was a new mom that couldn't see her her newborn, her infant, for 60 days that she spent here in the hospital. And we had to get her motivated to be able to participate in physical therapy and be able to get out of bed and regain that strength that was relatively easy to bring back given her age and the fact that she was relatively healthy before all this. And she was able to be listed as status 3 exception. We were able to proceed with transplant, watching closely her hematological profile, trying to achieve a hemoglobin that was stable and surveillance. But the effort for transplant was tailored. It was a very well thought out process that required multiple meetings and even dry runs to make sure that we have everything into place. And we had the collaboration of multiple teams that made this possible. The anesthesia collaboration was critical because of the cardiopulmonary bypass and changing the protocol to use normothermia to allow for decreased chance of developing a crisis immediately during the procedure. Cardiothoracic surgery, obviously, they have this gift of performing the surgery, but they also, help us navigate what was the best donor that we could get for her, considering she had recent lung injuries and considering size and assessing the recipient, which, by the way, on her way to the OR, she actually crashed, but due to diligence and skills of our surgeons, we were able to have a plan in place and proceed. Hematology, they guided us to survey for vaso-occlusive crisis in the immediate post-op. And perfusion medicine was able to help us with cardiopulmonary bypass, which can be used as a priming red cell exchange transfusion at the time of initiation of cardiopulmonary bypass. And what red cell exchange transfusion will do is it will decrease our percentage of hemoglobin S, which was in coordination planned with transfusion medicine to have a specific goal. Having said that, this patient, we had to perform red cell exchange transfusion in anticipation of transplant, just to be prepared. And within 3 days of listing is that she received an offer and was able to be transplanted. So this was overall a great team effort that we were able to offer to a patient with a rare disease who is already a minority for being a woman and African American in a community like ours. Thank you.
Yeah, Patricia, that was a great presentation. Just want to editorialize just for a second. The key point in the beginning that you made very nicely is that we felt that there are 2 reasons for crisis. One, the underlying disease, and the other one, shock. And I think the audience were all gung-ho for ECMO. But if this had been just a sickle cell crisis with severe hemolysis from the crisis and no shock, I think ECMO would be a mistake because the system would just clot. I just want to make that point. Second, we called around the country, including John Kabashigawa at Cedars and Donna Mancini, who was here with extreme experience. And I asked them, would you transplant this patient? And they both said, oh, she's very young. She just had a baby. You should go ahead. And then I asked, have you done it? And they both said, no. This was, yeah, and just a practical takeaway, which is going to be in our paper. The discussion with the blood bank was, we can just do plasma exchange, in the OR on bypass, or should we prepare the patient and do plasma exchange first when we feel that transplant is imminent in a week or so? And we decided for the latter to do it first. And sure enough, when she went on bypass, she crashed. and we couldn't have, done anything at that time. So just wanted to make these 2 points, but that was great.
Yeah, just to add to that, I think it shows that we know sometimes so little about what our colleagues do and the effort that it takes for them to perform their procedures. So it was a great collaboration to understand that, because a plasma exchange doesn't happen in a second. There's a machine, there's personnel involved, and we need to take that into account when we collaborate with other specialists. Thank you.
Thank you so much.
I think that patient's really lucky she ended up crashing at Montefiore and not one of those other circles that Snehal showed us. You guys gave her a good shot. Congratulations on that. It is a real pleasure of mine to be welcomed back home here at Montefiore. I want to thank Danny and Uli and the whole team here for the kind invitation to present at this year's Bronx Heart Meeting. It's really been a pleasure to watch this grow. And up until now, the quality of the presentations have been outstanding, and I've learned a lot. Transplant, as was mentioned by someone, has been relatively stagnant for several generations, and it's gotten exciting again. There's a lot of new technology. There are new devices. DCD is sort of the latest craze. I appreciate Snehal's lecture that highlighted state-of-the-art, current state, and I'm just going to hone in on one aspect of that. Danny's outstanding presentation, he gave us the illusion that a lot was going on in mechanical circulatory support, but really that's just one clinical trial where they created about 50 papers in high-impact journals and shuffled the authorship around. But most of the excitement is in cardiac transplantation. So the title of my talk that was handed to me was Donation After Cardiac Death. I'm going to start just by correcting the title. We now know that these hearts are not dead, they're very much alive. And so the correct terminology that we use is donation after circulatory death. Here are my disclosures, and I don't think they're relevant for today's talk. I'm going to start, I think it's important that I give you a little bit of a historical perspective of DCD transplantation, because it's actually where we started. And it's important to know that by necessity, we in transplant medicine push boundaries because we have to. And most commonly, those are clinical boundaries, but sometimes they're legal boundaries and sometimes they're ethical boundaries. And I think we have to be thoughtful and careful when we do that, because what we don't want to end up doing is eroding the public trust, because it's the public that we depend on for these organs that we transplant. So I think we have to be careful how we do that. And I'm just going to give a couple of examples of maybe where that's been done in the past and suggest that perhaps that's being done by some ways that we do DCD in the present day. So you probably all know that the possibility of heart transplantation has been around a long time. It was actually developed in the lab in the 1950s by Shumway and colleagues out at Stanford. And what delayed its making it to the clinic was an identification of an appropriate donor source. It wasn't clear where these hearts were going to come from. And actually, the very first human transplant was not done with a human heart, but was done with a chimpanzee heart. And that was done at the University of Mississippi by James Hardy. James Hardy had made himself famous by successfully transplanting the first human lung the year before. He had been emboldened by some success that Keith Reemsma, then at Tulane, had with using chimpanzee kidneys into humans, and thought it might be possible to use a chimpanzee heart into a human. He had a patient in his hospital who was, by all accounts, a terrible transplant recipient. He was a bilateral amputee from severe peripheral vascular disease, and he was in a degenerating condition and was brought to the operating room to try to do a corrective procedure. But he sought consent from the patient's sister, the next of kin, on this operative permit to have permission to potentially do a transplant. I just want to read a little bit of this for you. If for any unanticipated reason the heart should fail completely, I agree to the insertion of a suitable heart transplant, if such should be available at the time. I further understand that hundreds of heart transplants have been performed in laboratories throughout the world, but that any human heart transplant would represent the initial transplant in man. In other words, they were being honest. If they did a transplant, this would be the very first transplant done in the world. Nowhere on that consent form does it suggest that they might use a chimpanzee heart, which is what they did. As you might imagine, that didn't end well. We now know that there are tremendous immunologic barriers to transplanting across species that we're still grappling with 60 years later. We were certainly not ready to do it in 1964, and he was roundly criticized for having attempted that, and perhaps rightly so. It was a few years later before the very first successful human heart transplant using a human allograft was performed, and that was in 1967 in Cape Town, South Africa. That's the surgeon there. I think we saw his picture yesterday, Christian Bernard. The recipient shown there sitting out of bed a few days after that successful transplant. You'll see on the right the cover of the local newspaper the next day after that operation was performed, which was a momentous event in the world. You see that the donor and the recipient's pictures, their names, their stories are featured prominently on that. That, of course, is strange for us to see today because the anonymity of our donors and recipients is strictly protected. It's also, I think, important to understand how that first transplant was done. The donor was a 24-year-old woman. She was crossing the street to pick up a cake from a local bakery, and they were struck by an automobile. The mom was pronounced dead at the scene. The daughter was taken to the hospital in Cape Town. She was attended to by neurologists and neurosurgeons, and they determined that her brain was no longer functioning. There was a concept of brain death at the time, but there was no legal definition of death that involved the brain not working. And so for her to die, the heart had to stop. Because the brain wasn't functioning, they sought consent from the patient's father to use her as an organ donor. That was given, and the next day she was brought to an operating room adjacent to the recipient there. They removed her from life support. I believe it was Christian Bernard himself who took her off the ventilator. When the heart stopped, she was, after a brief standoff period, they opened her up, put her on the heart-lung machine. They resuscitated the heart, cooled it, took it out, and transplanted into him. And that's how the first handful of transplants were done, probably more than the first handful, because in order to die, the heart had to stop working. That, of course, is a description of what we would now call donation after circulatory death, and that's how it all started. The results with transplant were terrible in the early days, and most programs that started doing transplants completely abandoned it because it was common that patients died either at the index hospitalization or within the first few months, and very few of them lived beyond a year. One of the big events that improved results was the establishment of brain death as a clinical and a legal concept, and this began with the Harvard's ad hoc committee, where they titled it A Definition of Irreversible Coma, and that was published in JAMA in 1968, that very next year. They cite two reasons that are both practical reasons for why this definition was necessary. One, quote, the burden is great on patients who suffer permanent loss of intellect, love that one, intellect, on their families, on the hospital, and on those in need of hospital beds. And the second one was obsolete criteria for the definition of death can lead to controversy in obtaining organs for transplant. So it is very true that brain death was made as a clinical concept and as a legal concept to give us access to organs. And I think there were probably some in the public that were rather frightened of that. Perhaps they should have been. Here's an example. So brain death is now ratified by all 50 states. It took a number of years for that to happen, for people to recognize that. This is still in 1968, later that year after that paper came out. The laws had not changed at all. And Dick Lauer and team at the Medical College of Virginia thought they had an appropriate donor. The donor happened to be an African-American laborer that had fallen and struck in his head. He was admitted to their local emergency department. And again, they decided that the patient's brain was no longer working. They made a cursory attempt to find family, identify next of kin. They were not able to. And within 24 hours of that patient being admitted to the emergency department, they were used as an organ donor. They took the heart out to do the 16th transplant in the world and also used the kidneys. The family found out only later when they came to claim the body and they inquired what the big incision was from the top to the bottom, that only then did they learn that that person had been used as an organ donor. And as you might imagine, that resulted in a lawsuit. Fortunately for transplantation, they were exonerated and found to be not guilty because the judge determined that the patient was dead. But if they had ruled by what the legal definition was at the time, I think they would have been convicted of manslaughter. So another example of perhaps pushing boundaries that maybe shouldn't have been pushed quite so quickly. In the United States now, we have a federal definition of death, the Uniform Determination of Death Act, that's recognized by all 50 states in some form. And it declares that a person is dead if, number one, there is irreversible cessation of circulatory and respiratory functions, or number two, irreversible cessation of all functions of the entire brain, including the brainstem. It's that word irreversible that sometimes brings us into controversy with our present practice of DCD transplantation. Snell-Hall pointed out that the vast majority of our organ donors for the last 50 plus years have come from category 2. Brain dead donors that we bring to the operating room in a very controlled fashion, procure the organs, and we can do that because they've already been declared dead. Another very important concept or rule in transplant is the dead donor rule, and this was enacted in 1988 by John Robertson, who was a medical ethicist, and it says that vital organs should be taken only from dead patients and that living patients should not be killed for or by procurement. And I'm sure everybody in this room agrees with that, but there's sometimes debate about whether some of our present techniques of DCD transplant might be violating the dead donor rule as well. So DCD transplant is new in heart, but it's not new in abdominal transplant. It's been around for decades. The group at University of Pittsburgh was important in establishing the ethics of DCD transplantation and how it should be done. And they thought it was important and argued that, quote, the physician certifying death must not be involved either in the procuring of organs or the care of the transplant recipients. You want to separate the procurement process from the care of the donor for obvious reasons. And number two, the surgical staff responsible for organ procurement shall in no way participate in the weaning process or in the donor's care. It is preferable that the operating team not be present in the operating room until the certification of death, except for skin preparation and draping. And any of you that have been on DCD procurements will know that we are kept very separate, and I would encourage you to go on them because they have a very unique feel, and it might change your perspective on the practice in general. This is what's happened in DCD transplant over the time with abdominal transplantation. It most readily took off with kidneys because that's the organ that's least susceptible to ischemic injury, followed by liver, and only more recently, not on this graph, have we seen DCD transplant in lungs and hearts. It's important to understand these Maastricht classifications because you'll hear this talked about, and in general, with respect to heart DCD transplant, we are talking only about category 3, and that is a controlled donation process with a witnessed removal and withdrawal of care because it's necessary that we limit the unnecessary ischemic injury of the heart because that is the greatest challenge. The big difference, of course, between brain dead donor procurement and DCD procurement is this warm ischemic period that we get. These donors are neurologically devastated. They don't meet the strict criteria of brain death, but we do not expect that they're going to have a meaningful neurologic recovery. And at the consent of the family, they are removed from life support. And if they expire, if the hearts stop beating in a reasonable period of time, and we think that warm ischemic injury is recoverable, we can somehow resuscitate those hearts and assess them for transplantation. That brings us to warm ex vivo machine perfusion. This was introduced already by Snell-Hall. This is not a new concept. This is from Oscar Langendorf's publication more than 100 years ago. And these things have been around a long time. We've known that we can perfuse isolated organs. They were actually trialed in the early days of transplant in order to move organs from one point to another, but they were associated with organ injury and edema and largely abandoned for the simplicity of cold storage on which we've relied for most of the history of heart transplant. This is what ex vivo perfusion looks like in the modern era. You saw this picture already of the machine on the left. It's essentially a miniature heart-lung machine. And when you hook a heart up and resupply oxygenated blood to the aorta, the heart will generally start to beat again within seconds or minutes. We can manipulate a few things on the machine. We can control the heart rate with pacing. We can control the aortic pressure with changes in pump flow. And we can adjust coronary blood flow also with infusions. We rely on visual inspection of the heart in the unloaded state. It is not doing work, and that's important to understand that it's in the unloaded state. And so we use a surrogate for heart health, which is the heart's utilization of lactate. And we know that hearts generally use lactate as an energy source when they're healthy. And so if the system lactate is going down over time, we think that heart then is healthy and usable for transplant. There are multiple potential advantages of an ex vivo perfusion system. A big one is that we can protect these hearts outside the body for extended periods of time, and we can travel long distances with the hearts to go from our donor center to the other. But importantly, we can also evaluate these hearts prior to transplantation. So in all these ways, ex vivo perfusion could extend the donor pool. So getting back to DCD heart transplantation, this is returned to the adult clinical arena in 2015 with this landmark publication in The Lancet by the group in Sydney, Australia, where they described the successful transplant of 3 patients using organs from DCD donors that were resuscitated on the organ care system by TransMedics. Now, this didn't come out of nowhere. They had done years of work. Peter McDonald and their group had done years of work defining the safe intervals that they could get away with in animal models. And they did all that prior to launching this clinical protocol. Their protocol was based on 3 assumptions. 1, donors and recipients would usually be located in different hospitals, and they would need to transplant that or transport rather that donor heart across long distances. If you're familiar with Australia, you know that it's a huge country separated by vast areas without populace. There would be no antemortem interventions permitted. In other words, you can't cath a donor and get that sort of information because the donors are not yet dead. And that recommencement of the circulation after circulatory arrest would not be permitted. They were operating out of a Catholic hospital. They knew that wouldn't be possible. So their program is relied entirely on ex vivo perfusion. When that protocol, or when that publication rather came out, we and I think many others were intrigued and wondered, could we apply DCD transplantation in our program? Could we do that safely? In order to understand that, we had to get some experience with the machine, which we did through our participation with the EXPAND trial. If you're familiar with that, it's using the OCS machine to evaluate extended criteria donors. So we got used to managing hearts on the machine and understanding what it could and could not do. We got a small research grant from our organ procurement organization to look at 6 donors within our region. We did modify the system a little bit so that we could get some hemodynamic data from these hearts. So we put pressure-filled catheters in the left ventricle that we could measure developed pressure with. And we took 6 hearts from our regions, patients aging in range from 28 to age 51. Oh, I'm sorry, these don't look right. They've turned, but some of the hearts we were able to make quite good. Some of the hearts less good. But we did learn that the lactate trends did indeed seem to correlate with function, and that when the hearts look good, their developed pressure curves and their compliance curves also looked quite normal. So we learned a lot from that experience. We did convince ourselves that ex vivo perfusion could preserve these hearts for extended periods of time, that it was useful to assess the suitability of these hearts, and that the lactate trend did indeed seem to correlate with function. Importantly, our procurement teams and learned a lot about the timing of these DCD procurements. They're quite different from brain dead donation procurements. Dealing with things like hyperkalemia within the perfusate, you have to get experience with. Learning how to get the blood out of the donor to prime this machine expeditiously. It doesn't interfere with the liver teams is important. And that communication and coordination with those other procurement teams is really, really important. So by 2017, after having done all that, we were ready to launch our program, and we're really excited about doing DCD transplants. Unfortunately, TransMedics would not let us use their machine. They were waiting for the FDA to give them permission to launch a multi-center clinical trial. And so we had to await that trial to commence, which took a couple of additional years. You should know that there are 2 different ways that you can do DCD transplant, and both seem to be safe and both seem to be effective. What I described for you so far has been the ex vivo approach. There is also an in situ approach, which is often referred to as normothermic regional perfusion, where the donor heart is resuscitated within the donor patient. That requires occlusion of the vessels to the brain so that you don't reperfuse the brain, and that needs to be done before restarting the circulation within the donor. This is an example of one such technique of doing that. This was published in the JHLT. I didn't see any negative press over this, but you'll notice that the donor's been cannulated in the groin, and that happens prior to withdrawal of care. So you now have your procurement team and your anesthesia team attending to the donor patient prior to them being a donor. They're still alive, and doing an invasive surgical procedure Then the care is withdrawn, and when the heart's expired, they're opened up, head vessels are clamped, machines turned on, donor hearts resuscitated, and then it can be removed and transplanted in a usual fashion that you might use for a brain dead donation. So this does work, but I think that the way in which we do this should be carefully considered with some of those concerns that I mentioned previously in mind. There are a lot of advantages to doing it that way. It's cheaper, it's fast, you get a full hemodynamic assessment of the donor heart in the working mode, which is important, and it did not require any FDA oversight. So some of the teams that have chosen to use this technique in the United States were out in front because they could do that without needing an FDA-approved clinical trial for a commercial device. I think the big disadvantages are that it requires the heart to be rearrested, and then generally some sort of cold storage is used, which kinds of limits the distances that you can travel with these hearts. I do believe that there are ethical concerns, and for that reason, this technique is not allowed everywhere in the United States. It's not allowed in all hospitals. It's presently not allowed in Canada, and there is a moratorium on it presently in the UK. It is allowed in many, many parts of the world and in many places here in the United States. The other technique I've already described for you that requires collection of donor blood. The organs are individually administered preservation solution and removed, but the circulation is never reestablished within the donor. Again, communication between teams is important. The advantages are that it maintains the donor organ in a warm, perfused state. I do think it's much less controversial for the reasons that the donor circulation is not restarted. The big disadvantage that people cite is cost. Required FDA oversight. It's now an approved device. Very importantly, you do not get a full hemodynamic assessment of the heart because it's kept in a non-working mode, and that is not optimal. We have amassing outcomes data now. This is out of the Australian group, the first 74 cases done, all using OCS. And then on the right, for the UK group has just published their 5-year experience using a mixture of both normothermic regional perfusion and OCS. Both groups show survival curves that essentially mirror standard brain dead donation transplantation. So it appears, at least in Europe and Australia, that this can be done safely. US data, we have data out of those initial centers. That's NYU on the left, small series of 8 or 9 patients, and Vanderbilt on the right, which I think was 17 patients, both showing outstanding outcomes with DCD transplantation, both groups using normothermic regional perfusion. We now have one prospective randomized clinical trial. This was just published last week. Danny already highlighted this for us. You guys were participating in this trial. This was again, utilizing Maastricht category 3 donors, controlled donation. The donors were young, less than age 50, and the warm ischemic time was supposed to be limited to less than 30 minutes. Warm ischemic time defined as the time the donor became hypotensive or hypoxic until the donor heart was administered cardioplegia. This has been our experience. You hook these hearts up to the machine. It sometimes does take them longer to start to beat, especially if the potassium is high in the perfusate, but generally they'll start to beat and look quite normal. The lactates, these bars here are the arterial and venous lactate, and the hearts tend to make lactate for the first about 90 minutes. Afterwards, they'll generally stabilize, and then the lactates will go down over time. And that tells us if the heart looks good and it's utilizing lactate, those are the metrics we generally use to know if this heart is safe to transplant. We were the second leading enroller in that trial. You see us next to Duke, who was the leading enroller within that trial. And those were all the centers that enrolled, that transplanted DCD hearts within the trial. There were other centers that were in the trial but never transplanted a DCD heart because only 90 were allowed. This was an interesting trial design. It was a 3-to-1 randomization, 3 patients that would randomize to the DCD possible arm, and 1 would randomize to the brain dead only arm. And it was done that way because we anticipated that it would take a long time to find and be able to transplant these DCD organs. What we found was exactly the opposite. These organs were readily available. A bunch of centers were gung-ho and ready to transplant them, and the DCD arm enrolled very, very quickly. And we had to wait to get 90 comparable patients transplanted with standard brain dead donors. Because the donors are very different and because access to these organs were very different, there's important differences in the donor and recipient characteristics that are worth noting. The DCD donors, they're very often drug overdose victims, and they tend to be younger and more commonly male. Importantly, in the recipients, they tended to also be younger, and they're lower down on the transplant waiting list, most commonly status 4 versus status 2 in our standard transplant practice. Also, more of them had durable VADs, and fewer of them had intra-aortic balloon pumps. So that group that's transplanted with a DCD arm looks very different from our standard transplant practice, which looks a lot like the standard of care or the comparable DBD group. But those groups are not entirely comparable, and that's important to at least keep in mind when we look at the survival curves. We were able to utilize almost 90% of these hearts. So these are hearts that 0% would have been used before this trial. So if a heart goes on the machine, there's about a 90% chance that we'll use it. And when we don't use it, it's usually because that lactate trend is unfavorable, as you see in the gray line to the right. We did note that there was a significant increase in moderate or severe primary graft dysfunction in the OCS group. It was almost 23% versus less than 10% in the standard group. I think some of that data that you guys have shown on the risk of PGD and early death, I think is skewed. I think we and transplant surgeons have learned that being aggressive with ECMO and not limping out of the operating room is really important, and that if you're early in your use of ECMO, you can very often rescue these patients, even with very significant initial primary graft dysfunction. That higher rate of PGD that we saw did not translate into excess mortality. They're the survival curves, and you can see that they're numerically better with the DCD group, which was super encouraging to see. Again, this is not completely comparable groups, and this is a non-inferiority trial. So DCD transplant was non-inferior. When we concluded that trial, we sort of ran out of an ability to do DCD transplants, and we sort of had we felt really guilty not using these DCD hearts, knowing that they work. So we decided to continue to transplant using the OCS in an off-label use, and we just published our experience with the first 47 patients that we transplanted using this machine. Some of these were within the protocol, and the rest of them were outside. So the last 27 were after the trial. We too saw a significant increase in severe primary graft dysfunction. It was just under 11% versus under 4% in our historical practice going back to 2016. This does not achieve statistical significance, but it clearly there's a little bit more PGD. This is what we saw in patients that consented for DCD donation. On average, we found them an organ in 17 days, and there was a marked reduction in wait time. And it looked very, very similar to what we saw in our hepatitis experience, which is up there on the right. When those, before that was standard of care and only a few of us were using those hearts, they were readily available, and that was a huge advantage to our recipients. These patients, if they don't suffer severe primary graft dysfunction, they look very, very similar to our other patients, but they're subtly probably different. This is hemodynamic data at our weekly catheterizations. And you can see that the right atrial pressure in these DCD hearts, that's the sort of bluish boxes, is a little bit higher. And by week 3, that normalizes. The PAPI scores are subtly lower for the first 2 weeks, and that normalizes by week 3. And the right atrial pressure to pulmonary capillary wedge pressure is also higher, all suggesting that there is some injury to these hearts that takes a few weeks to completely resolve. And there's probably some subtle care differences in how we manage them. We did get better at predicting donors that were going to expire. We went from 1 to 3, coming back without organs to about 1 in 5 coming back without organs. The warm ischemic time to the donors didn't change, and you wouldn't expect it to, and it averaged around 20 minutes. Our severe primary graft dysfunction incidence went way down over time. We have had some since then, so I don't believe it's 0. But I do think it does appear that there's a little bit of a learning curve with that as well. Our survival outcomes were excellent. It was 97% survival in the DCD group at 1 year, and appears very, very similar to our standard of care with brain dead hearts. Just a couple of more slides about maybe the things that we have to look out for and potential future directions of DCD transplant. This is Selena Lee is one of our outstanding categorical residents, and she just submitted this manuscript looking at the UNOS database in the first almost 300 patients transplanted with DCD organs. We do see that in the US practice, survival appears, if anything, better. It certainly doesn't appear worse than standard of care. But we saw that there does appear that there might be an increased risk of rejection, including increased rates of rejection prior to discharge, increased rejection within a year, and increased hospitalization for rejection. And in our multivariate analysis, the donor type being a DCD organ was the biggest risk factor for rehospitalization for rejection. So I think it's going to be important to follow these patients long-term to see how these hearts behave, and particularly the incidence of vasculopathy and other late-term sequelae. I think we're going to have to keep our eye on that. A couple of slides are Ali Rabi in our group is doing some, I think, really important work on metabolomics, looking at, the heart is a true omnivore. It's not just glucose and lactate that it uses ketones, fatty acids, and a number of other things to generate mitochondrial energy. And by looking at these multiple assays and looking at what is happening in the perfusion system over time, what the heart is making, what it's consuming, I think is going to be really important. And then we can use machine learning to look at these metabolic networks to better understand exactly what's happening with these hearts on the machine. And I think importantly, it might give us the ability to resuscitate some of these hearts that we're now turning down. If we know what to add to the perfusate, that might make a really big difference. So there's clearly a huge clinical appetite for DCD transplant in the US. This is what's happened since the first ones were done in 2019. We did almost 350 last year, and it's going to be really exciting to see what we do this year. And this has been an important part of an increasing numbers of transplant that are done. We did more than 3,500 adult transplants last year, more than we've ever done in the United States. And a big part of that appears to be the additional organs we're getting from DCD transplant. In our practice, it's about half of the hearts we're using now. That will obviously go down as more centers open up DCD programs. It'll become a little bit more like hepatitis, but it still is about half our organs. And I think we're doing another one today. And this is, the effect of what, an aggressive transplant program can do if we really try to utilize every donor organ available. That's our transplant program since it began in 1986. Last year we did 54, which is the most we've ever done at the MGH. So just to summarize a lot of what I've told you, DCD heart transplant is certainly possible with good medium-term results. There obviously is an associated learning curve. I think it's really important that we learn from each other and that the patients don't suffer that learning curve. There's a long-term behavior of these allografts I think needs to be carefully scrutinized, as I mentioned. I do think there are ethical and legal issues that need to be addressed, and those are best addressed by the transplant community, but we have to protect ourselves from ourselves. As I said at dinner last night, we are predators on donors, and we have to be careful how we do this so that we don't erode the public trust. And finally, ex vivo perfusion, I think, affords tremendous opportunity to assess, but also to optimize donor heart function prior to transplant. So I think it's a potentially really powerful tool that we're just really beginning to learn how to use. Last slide, we just transplanted our 750th transplant a few weeks ago, and it's been really gratifying for me to work alongside really dedicated group of doctors, nurses, and everybody on the team that dedicates themselves to the care of transplant patients. I have that at MGH. I certainly had that when I was here, and I see that the team is alive and well, and congratulations on those results, and thank you for having me back.
Thank you, Dave. That was really terrific. It's one of the best DCD talks I've heard. Dave tends to be humble, but when you saw the volume curve in MGH, this is pretty much a program that was doing 10 to 12 transfers a year for its entire history. And when Dave got there, the quality, the volume, the enthusiasm exploded. I attribute it largely to Dave. This is sort of a single person that took on the lead and brought the whole team together to make this happen. It's now the dominant program in Boston where there's a fair amount of competition. So congrats, Dave, and thanks for coming. It's always great to see you.
Thank you.
We have a question. Yes.
Hi, Dave. Excellent presentation. So I have two questions for you. One is when we look at the DCD literature coming from Australia, and then the same that you've shown from your center, that the rate of severe primary graft dysfunction, the conclusion at the end of the paper is always that we have seemed to improve with time. But are there any strategies which I don't think was mentioned in the paper, but what exactly happened during that time and what we got better at? That's one. The second question is in terms of increased rejection that's observed in the DCD transplants. Just the way we are procuring these organs, that should not make them more immunogenic to. Do you think, and that's something that when we published last year in JAC, we saw as well, that there was probably more rejection, it did not reach statistical significance. Do you think that's happening because more of the LVAD patients are the ones that are getting the DCD? So it's the recipient, not the donor itself.
Yeah, I'll answer your second one first. I think it's certainly possible that there are differences in recipients. When you look at people that are getting DCD organs versus people that are getting standard brain dead organs, the recipients are very different, as you mentioned, and certainly that could play into it. And some of what I didn't show you from that paper, we looked at the risk across status groups appeared to be the same with brain dead, but it was consistently higher with DCD. So I think it probably is more likely the endothelial injury that these hearts probably suffer that may, and the inflammatory response to that. It also could be that the slides are just being read differently because we've never really had DCD hearts to look at. And so it may be that what they're reading as rejection is really inflammation or ischemic perfusion and reperfusion injury that might mimic rejection. So I think it's multifactorial, but I do think these hearts sustain an injury. And while the function is good, I don't know what the long-term sequelae would be. I don't think it's going to be important. Obviously, I'm a big fan of it. And that people, and then the first question about the incidence, when you use the OCS machine, there's different ways of managing the heart pressure, high pressure, low, coronary blood flow, high, low, and you sort of get better over time of how to manage hearts so that they look good and they start to consume lactate. And I think the more experience you have, the better you get. The groups that use normothermic regional perfusion argue that there's less PGD, and that in fact may be true. I don't think that means we should use it over the other necessarily, but it might be better for the heart to resuscitate the heart within the donor.
Yeah, just quick question. Amazing presentation. You have 97% 1-year survival and 10% go on primary graft with ECMO. So I guess you're doing well with the ECMO. Do you vent these patients or no?
Generally, I don't vent. I had a patient die recently that clotted his entire heart. I had to take the heart out, unclot it, and put it back in. And he survived that, but didn't leave the hospital. Since then, I vented, but usually with a transplanted heart, there's enough function that you don't need a vent. And sometimes with a vent, I think it can promote thrombosis, having that foreign body in there, especially if you're holding anticoagulation. So I think vents can be a double-edged sword. And no, we don't typically vent, but there are certainly times I do think it's appropriate to vent.
Quick question. Great presentation, Dave. When you were assessing these organs for recovery, how have you managed to reduce the rate of coming back empty-handed just 1 out of 5 times? What factors are you looking at?
Yeah, I think for me, the most important one is what the respiratory drive is. If there's a strong respiratory drive and they're not on a lot of respiratory support, we don't go unless they're local. If they're local, we go on all, if it doesn't involve a plane ride. One of the reasons that I think we got better at it is during the trial, we kind of had to go because if you didn't, someone else was going to go. But after the trial, nobody was using these hearts, so we could all of a sudden be super selective, and it didn't matter if we turned this one down. We had 2 more the next day, and so we just we're more selective about who we chose. As this becomes standard of care and those DCD donors become less common, then we're going to all have to be more aggressive, or we just won't get them. But respiratory drive, I think, is one of the most important ones. How much they're overbreathing the vent, because if you extubate them. But yeah, there are subtle things like how long have they been on the vent, what's the pressures that they're on, whether they're going to turn those on and off. There's a lot of additional questions you can ask the OPO to get some information that can inform that decision.
David, great presentation. I have one question and a comment. One question, how easy is it to manage the heart with the OCS? Because I know, 10%, you're losing those hearts. So as this gets implemented in more places, do you think everyone has the experience to do this, or do you think it takes a learning curve?
Yeah, as organ procurement gets more complicated, there is clearly an argument that could be made that individual centers should not be doing it. We should be giving it to industry or some group that specializes only in organ procurement. And you certainly will not suffer that learning curve as readily if you use the OCS national team, that at least the perfusion part of that, they'll manage it for you. And they lose money if you don't use that heart. So it's really important to them that they make that heart work. So we've been doing it long enough and now we have enough team experience that we can do that ourselves. But it took a while to get there. And I think for all of our programs to get there is going to be costly. And smaller programs probably ought to use the OCS national system.
Then just one final comment regarding the ethics concern of doing first of NRP in general. I think, if you clamp all the subaortic, I think you're pretty sure you're not getting any blood to the brain. Obviously, you have the posterior circulation, but we have to prove that there is no reperfusion to the brain. I think that is an issue that has to be addressed. Actually, in Spain, we are doing some research into that. So I think that is a critical point because, as you say, it is very important that we have the public trust, and we can't lose that.
And you in Spain have really led the way to helping to figure this out and understand how we can prevent cerebral reperfusion, and you should be congratulated for that. The views that I express on the ethical issues are mine. Not a lot of people think there's a big issue, and most people think that NRP is the way we ought to go. For me, there's something uncomfortable about reestablishing the circulation, and you're not the person taking the organ out, but I can tell you that clamping the head vessels to prevent them from waking up to reestablish seems like an active thing that the surgeon is doing that's participating in somehow in the process of death. And for me, that feels odd. It doesn't for most people, but I think it's a discussion worth having.
I think it's we have to accept that people have concerns, and then another issue is whether you do things before circulatory death. So that is, I think, an important issue. But this has been going on with abdominal organ reperfusion for a long time.
Right.
At least in Spain, we've been putting the NRP before.
Yeah.
When we were doing abdominal organ.
Yeah.
So I think, I don't really understand why that has been going on for many years.
Mm-hmm.
And suddenly when we're doing the heart, that is an issue.
I think those are great questions, and hopefully our ethical and legal teams will help us answer them over the next couple of years. We have time? Okay, we have. Yeah.
Make this quick announcement we're running a little bit late. We'll continue here, but for those of us who are watching us on Zoom or YouTube, which are around 200-300 people, thanks so much for joining us. Unfortunately, you will get kicked off this link in a minute, but you can enjoy the MonteHeart imaging lecture, which will continue on a different channel. So thanks very much, those who are attending virtually.
Thanks. Okay, our last presentation.